Good evening, everyone. I'm audible and visible to all of you guys. Please update me in the comment section. Am I audible and visible to all of you guys? Yes. Thank you. Good evening, everyone. I hope you all are doing good and you all are preparing for the exams. We are coming closer. So welcome to the session, most awaited part 2 for the PSM. And today again, we are going to discuss the left topics for the PSM. We are going to discuss the questions, and followed by each questions, we are going into the depth discussion of that particular question. And mostly we'll be covering the recent NEET PG exam questions that have been asked multiple times. Okay. So meanwhile, be interactive. Okay. Keep answering in the comment section so that we can learn and remember all the things, because PSM is not conceptual things mainly. You just have to remember. Okay. So let's remember and memorize all the PSM as much as we can. So without any further delay, let's begin with the first question. Question number 1, that's going to be which of these is the correct dosing schedule according to the given program logo? So the given program logo, you already know, that is Anemia Mukt Bharat. What is the given program logo? It's an Anemia Mukt Bharat. So about all the statements given, which of the following is the correct one? Comment down the answers in the comment section. Yes. So let's discuss whole Anemia Mukt Bharat, and then followed by that we'll go to the answer. If I talk about an Anemia Mukt Bharat, this was a scheme launched by the government in order to decrease the prevalence of anemia, in order to decrease the prevalence of anemia by 3% every year. Decrease the prevalence of anemia by 3% every year. By 3% every year. Okay. And it follows the strategy 6 into 6 into 6 strategy, which means 6 beneficiaries, 6 institutional mechanisms, and 6 interventions. Okay. Now as per Anemia Mukt Bharat, we have a different age groups, and according to that we are giving iron and folic acid. We are giving iron and folic acid. If we talk about 6 months to 5 years, if we talk about 6 months to 5 years, the iron given is 20 mg and the folic acid given is 100 micrograms. The folic acid given is 100 micrograms. Okay. And the frequency is, it's given twice a week. It is given twice a week. Okay. If I talk about 6 years to 10 years, if we talk about 6 years to 10 years, the amount of iron given is 45 mg. The amount of iron given is 45 mg, and the folic acid is 400 micrograms weekly. 400 micrograms weekly. Followed by that, if we talk about 10 years to 19 years, 10 years to 19 years, the amount of iron given is again 60 mg. Followed by that, folic acid given is 500 micrograms. Again, this has to be given once a week, weekly. Next, from 19 years to 49 years, from 19 years to 49 years, the amount of iron given is 60 mg of iron and folic acid of 500 micrograms. Again, you are going to give weekly. Then the most important one that has been given in your question is pregnancy and lactation. Pregnancy and lactation. In pregnancy, we are giving 60 mg of iron and 500 micrograms of folic acid daily. Also in lactation, 60 mg of iron plus 500 micrograms of folic acid every day. Okay, now this has to be given. If the question mentions according to this Anemia Mukt Bharat, then your answer is going to be, yes, then your answer is going to be 60 mg of iron for 500 micrograms of folic acid. But if the question mentions generally how much of folic acid you will be giving, not 500 micrograms daily. If a patient is having a history of a neural tube defect, if a question mentions the patient has a history of a neural tube defect, for example, they will mention there was a spina bifida in the first pregnancy. Now, what will be the dosage of a folic acid? Then your answer is going to be 4,000 micrograms. Then your answer is going to be 4,000 micrograms. Okay, so remember that if question mentions Anemia Mukt Bharat as per AMB, answer for folic acid is going to be 500. If generally they ask 400, if they mention the history of a folic acid, then your answer is going to be the 4,000 micrograms. 4,000 micrograms. Is that clear? Is that clear? Okay, next is going to be about the iron. Let me mention about the iron as well. Iron, you are giving 100 mg per day generally, not as per the Anemia Mukt Bharat. If a patient is having mild to moderate anemia, you are giving 200 mg per day. Then your answer is going to be 200 mg per day. 200 mg per day. Okay, 6 to 10 years twice a week. No, 6 to 10 years is going to be weekly. Okay, that's going to be weekly. Is that clear? Okay, if you want to remember the color, guys, if we talk about the color, in syrup form mein denge, then the color of tablets is going to be pink, then blue, followed by that it's going to be red color. Okay, so that's why folic acid is given in order to prevent the neural tube defects. And if I talk about the most common neural tube defect, answer me in the comment section. What is the most common neural tube defect? What's the most common neural tube defect? Shehzad, 5 grams in the skill cell, 5,000 micrograms. Okay, but history of neural tube defect, it's 4 grams, that's 4,000 micrograms. Okay, what's the most common neural tube defect? That's going to be your spina bifida. Okay, most common neural tube defect is going to be spina bifida. And the question in your exam was asked that lemon sign and banana sign. This is the classical two signs are seen in which condition? Your answer is going to be spina bifida neural tube defect. Okay, now the given question, what will be the answer for the given question? 20 mg iron, 100 mg folic acid. No, the answer is going to be C, that's 60 mg of elemental iron plus 500 micrograms of folic acid to the pregnant lady every day. Is that clear to everyone? Let's move to the next question. For a pregnant woman, what is the ideal antenatal visits? So what is the ideal antenatal visits in a pregnant woman? Write down in the comment section, guys. Okay, let's talk about average visits. So average visits for a pregnant lady are around 12 to 14. They are around 12 to 14. Okay, if I talk about every month, till 7 months, there should be one visit every month till first 7 months. Then there should be every 15 days in 8 months. Every 15 days in 8 month. Followed by that, there should be every week in 9th month. There should be visit every week in 9th month. So around how many visits? That's 7, 2 is 9, plus 4 is around 12 to 14 visits are the average antenatal visits. Okay, if I talk about minimum antenatal visits, if I talk about minimum antenatal visits, minimum antenatal visits are 4. Minimum antenatal visits are 4. Okay, and as per WHO, okay, as per WHO, the minimum antenatal visits are 8. Minimum antenatal visits are 8. Is that clear to everyone? Is that clear to everyone? Yes, you already know these things. Just try to be interactive, just try to answer in the comment section, so that it will be a revision for you guys. It will be a revision for you guys. Is that clear to everyone? Okay, let me add on a bit more. Sir, how exactly we need to go for these 4 visits? How exactly we have to go for these four visits? Okay, let me mention that as well. How exactly you have to go for these 4 visits. Visit number 1, first trimester. First trimester, there will be first visit. Then 14 to 26 weeks, second visit. Then 28 to 34 weeks, that's going to be your third visit. And 36 weeks till the delivery, that's going to be your fourth visit. So minimum of 4 visits should be antenatal there. Okay, now what they can ask is, what about the postnatal visits? How many postnatal visits should be there? Write down in the comment section. What about the postnatal visits? What about the postnatal visits? Anyone? What about the postnatal visits? Yes, postnatal around 5 to 6. Okay, if home delivery, that is going to be 4 visits. If hospital, 3 visits. Is that clear? 1, 3, 7, 42. So the answer for this question is, for a pregnant woman, the ideal antenatal visits are 12 to 14 visits. Okay, minimum antenatal visits are 4, and as per WHO, there are 8 visits. Okay, is that clear to everyone? Write down in the comment section. Yes, clear? Chalo, next question. The recent transmission of malaria can be calculated from. The recent transmission of malaria can be calculated from. So we have indicators of a malaria, guys. We have annual parasite incidence, we have infant parasite rate, we have slide positivity rate. Okay, so recent transmission of malaria can be calculated from. Let's discuss about the indicators of malaria. Let's discuss about the indicators of malaria. First of all, we have an annual parasite incidence, API. We have annual parasite incidence. What exactly is annual parasite incidence? It is number of new cases. It's number of new malaria cases. It's number of new malaria cases upon 1000 population. Per 1000 population. Okay, and the significance, if I talk about the significance of this API, if I talk about significance of this API, it tells me about, it suggests about active disease transmission. It's a suggestive for active disease transmission. Okay, so number of new malaria cases per 1000 population is the annual parasite incidence, and the active disease transmission is the significance. Okay, if I talk about the infant parasite rate, it's the best indicator for recent malaria transmission. It's the best indicator for recent malaria transmission. So the best indicator for the recent malaria transmission, your answer is going to be infant parasite rate. Then the annual blood examination rate, ABER, is the best indicator for, it's the best indicator of operational efficiency of worker. best indicator of operational efficiency of worker. Then we have a slide positivity rate. It's a percentage of positive slides examined. It's a percentage of a positive slides examined. Okay, so remember guys, API, it has been asked multiple times, and the infant parasite rate. So best indicator for the recent transmission of the malaria, your answer is going to be infant parasite rate. Okay, so the recent transmission of the malaria can be calculated from the IPR. API is going to tell me about an active disease transmission. Okay, and slide positivity rate is going to tell me about the number of slides examined. Okay, now let's move to the other part of the malaria that have been asked repeatedly. What they usually ask from the malaria is going to be the diagnosis, the treatment. Okay, the diagnosis and the treatment. Now if I talk about the agents of malaria, what are the agents for the malaria, right? We have Plasmodium, we have falciparum, we have Plasmodium vivax, we have Plasmodium ovale, and malaria. So these are the agents of malaria. Okay, if I talk about diagnosis, this has a question asked. If I talk about diagnosis of a malaria, we go for the first peripheral blood smear examination. We go for the peripheral blood smear. Okay, in peripheral blood smear, my dear students, we are taking how many smears? We are taking 2 slides. We are taking 2 slides. The 2 slides that we are taking, one is going to be thin, the another one is going to be thick. One is going to be thin, another one is going to be thick. Thin will tell me about species of malaria. Thin will tell me about the species. Thin will tell me about species of malaria. Okay, and thick will tell me about the confirmation. Thick will tell me about the confirmation of malaria. Okay, thin species of malaria and thick confirmation of malaria. And these slides are prepared by multi-purpose worker male at primary health center, at PHC. So first of all, we are going to prepare the 2 slides. The thin is going to tell me about the species of the malaria, and the thick is going to tell me about the confirmation of malaria. Then we have a rapid diagnostic kit. Okay, we have a rapid diagnostic kit. It detects an antigen, protein, histidine rich protein. So write it down, rapid diagnostic kit. We have a rapid diagnostic kit. It detects an antigen. Okay, antigen detected. Which antigen? It's going to be HRP2. Again a neat PG PYQ guys, histidine rich protein. That's going to be histidine rich protein. Histidine rich protein. Okay, so histidine rich protein, antigen detected in case of an malaria. Okay, now most important part that has been asked is going to be the treatment. Okay, the most important part that's going to be the treatment. If I talk about the northeastern states, we have ACTL plus P. That is going to be artemether. That's going to be artemether, lumifentrin, and primaquine. That's going to be artemether, lumifentrin, and primaquine. If I talk about other states, the treatment is going to be, yes, write it down in the comment section guys. What will be the treatment in the other states? That's going to be ACTSP plus P. What is that? That's going to be artesunate. That's going to be artesunate plus sulfadoxine artesunate plus sulfadoxine plus primaquine plus primaquine, artesunate, sulfadoxine plus primaquine. But this treatment is usually for the falciparum. This is usually for the falciparum. Remember that, falciparum. If they mention that it's due to the vivex, then the chloroquine is drug of choice in all states. If it's Plasmodium vivex, if it is Plasmodium vivex, then the drug of choice is going to be chloroquine. Then the drug of choice is going to be chloroquine. Is that clear? Yes, is that clear? Then the drug of choice is going to be chloroquine for the vivex. Okay. Now next is going to be malaria with pregnancy. Now in case the malaria happened in the pregnancy, what will be your answer? They usually ask from the OB/GYN point of view. Sir, if in pregnancy they ask it is due to the Plasmodium vivex, if in the pregnancy they ask it is due to the Plasmodium vivex, then the drug of choice for all trimesters, then the drug of choice for all trimesters is going to be chloroquine. Then the drug of choice for all trimesters is going to be chloroquine. Okay, remember that in pregnancy primaquine is contraindicated. Primaquine is contraindicated. Okay, but if they mention that it is due to the falciparum, if they mention it is due to the falciparum, in first trimester, the answer is going to be, write down in the comment section, in first trimester, in case of a Plasmodium falciparum in first trimester, what will be your answer? What will be the answer in case of a first trimester? Yes, answer is going to be quinine. Answer is going to be quinine. Okay, and in case it is in second trimester, again northeastern, in second trimester again northeastern is going to be ACTL and other is going to be ACTSP. That's the treatment for malaria in pregnancy. Okay, so vivex, the drug of choice is going to be chloroquine for all trimesters. Falciparum, the first trimester, your answer is going to be quinine. Your answer is going to be quinine. Second trimester northeastern, ACTL, and other it's going to be ACTSP. Other is going to be ACTSP. Is that clear to everyone? Yes. If normal malaria, my dear students, normal person, the vivex drug of choice is going to be chloroquine in all states. If it's falciparum, your drug of choice in northeastern is going to be ACTL, that's going to be artemether, lumefantrine and primaquine, and other states it's artesunate, sulfadoxine and the primaquine. Okay, now if I integrate it a bit with the pharmacology, can you tell me what are the side effects of chloroquine? Very important side effect of chloroquine. Very important side effect of this drug chloroquine. What's the important side effect of a drug chloroquine? Anyone in the comment section? Yes. What is a side effect? What is the side effect? Second and third trimester onwards, that is ACTL, ACTSP. Okay. Side effect of a drug chloroquine. Yes, it causes QT prolongation, but from the ophtha point of view, it calls bull's eye. Bull's eye and QT prolongation. Bull's eye. Oh yes, bull's maculopathy. Very good. Bull's maculopathy. Is that clear? Bull's maculopathy. Very good. It causes bull's maculopathy. Okay. Chalo. Bull's neck is seen in, if I talk about bull's neck is seen in which condition? Yes. bull's neck, that is going to be your diphtheria. That is going to be diphtheria. Okay, now if I talk about prophylaxis of the malaria, we have two types. Either we give a short prophylaxis or the long prophylaxis. Okay, so remember guys, first of all, the duration of the prophylaxis. So if we talk about the duration of a prophylaxis, we have to give it 2 weeks before and to 4 weeks post return. 2 weeks before and 4 weeks post return. Okay, what are the drugs we give? We give, first one, we give doxycycline, we give mefloquine, we give atovaquone, we give atovaquone. Is that clear? So doxycycline, mefloquine and atovaquone. Remember guys, this doxycycline is termed as up till 6 weeks only, less than 6 weeks. Okay, it started 1 day prior to the place you are going and 4 weeks post. And mefloquine, it's a long-term prophylaxis, 2 weeks prior, okay, and then 4 weeks post return. Is that clear? Okay, so that's all about the malaria. Is that clear? That's all about the malaria. Anything else you remember about the malaria? Can you tell me what is the granuloma seen in the malaria in the comment section? From the pathology, what is the granuloma seen in malaria? Prophylaxis is clear, 2 weeks before to the 4 weeks post return. Drugs are mefloquine, atovaquone and doxycycline. Doxycycline is given 1 week prior to the 4 weeks post return, and mefloquine is given 2 weeks prior to the 4 weeks post return. That's why doxycycline is a short prophylaxis and mefloquine is a long prophylaxis. Is that clear? Now what is the name of the granuloma in case of malaria? Anyone in the comment section? Yes, you guys are closer to the exams. Patho is almost done. You might have revised your patho, so answer in the comment section. Yes. Anyone in the comment section? Yes. It started with D. Yes. Chalo, it's a Dirk granuloma. D-U-R-C-K, Dirk granuloma. Yes, yes, it's a Dirk granuloma. Very good, Ojaswani. It's a Dirk granuloma. Chalo. Next question. So the answer for this you already know, infant parasite rate. Let me have a quick review. Annual parasite incidence will tell me about an active disease transmission. Guys, they will ask these questions. Recent malaria transmission, infant parasite rate, annual blood examination, the best indicator for the operational efficiency of the worker, and the percentage of the positive slides examined, that's going to be the slide positivity rate. Is that clear? Then malaria agents, you know, remember we are going to take 2 slides. We are going to take 2 slides, peripheral blood smear. Thin is going to tell me about the species and thick is going to tell me about the conformation of the malaria, and it's prepared by the multi-purpose worker male at PHC. We are going for the rapid diagnostic kit. It detects an antigen. The protein is histidine rich protein. This has been the question asked recent exams. Then in case of a Plasmodium falciparum, the treatment is going to be ACTLP, artemether, lumefantrine and primaquine. In other states, it's going to be ACTSP plus P, that is going to be artesunate, sulfadoxine plus primaquine. If in case of a pregnancy, Vivex, the answer is going to be chloroquine. For all trimesters, the falciparum, the first trimester is going to be quinine, second trimester, then followed by that, if it's northeastern, you go with ACTL, and if it's other state, you go with ACTSP. Primaquine is contraindicated. Prophylaxis 3 drugs, we have doxycycline, mefloquine and atovaquone 2 weeks prior to the 4 weeks post return. Is that clear to everyone? Now let's move to the next question. Which of the following options best defines the correct sequence of the phases of demographic cycle? Okay, this is a recent NEET PG question. Tell me the correct sequence of the phases of the demographic cycle. This is a demographic transition model. So what will be your answer? What will be your answer, bacho? Write down in the comment section. Yes, the answer is going to be high stationary, early expanding, late expanding, low stationary, and declining. So the answer for the given question is B. That's high stationary, early expanding, late expanding, low stationary, and declining. Let's understand each of the following phases. The first phase is going to be high stationary phase. The first phase is going to be the high stationary phase, in which the birth rate is very high. The birth rate is very high, and the death rate also is very high. Birth rate and the death rate both are high. The population size is going to be stationary. The population size is going to be stationary. Okay, if I talk about the next phase, that is an early expansion. The birth rate in early expansion is very high, and the death rate starts decline. The death rate starts decline, and about the population, it will start increasing. The population will start increasing. The next one is the late expansion. The birth rate starts declining. Okay, and death rate continues to decline. What will happen to the population, guys? It will increase, but at the slow rate. And India is in phase 3, that is late expansion. India in which phase of a demographic cycle? That's going to be late expansion. Okay, then we have low stationary. The birth rate is very low. And death rate also is very low. And what will happen to the population? That's going to be stationary. Okay, reversal or the declining, it's when the crude death rate is more than the crude birth rate. So almost birth rate is 0. That's almost 0. The death rate, it starts decline, and the population eventually decreasing. Okay, the deaths are the natural deaths. Is that clear? So these are the phases of a demographic cycle. Demographic transition model. Okay, so the sequence is going to be high stationary, early expanding, late expanding, low stationary, and declining. Is that clear? Again, this has been the recent question asked in the NEET PG exams. Next one, epidemiology is the study and analysis of the distribution patterns and the determinants of the health and disease condition in defined population. Which among the following correctly defines the generation time? What will be your answer? Write down in the comment section, guys. The first one options are interval between the marriage and the birth of a child, interval between the entry of an organism till the maximum infectivity, the interval between the primary and the secondary case, or the interval between the entry of infectious agent and the symptom of disease. So what will be your answer for the given question? Yes, what exactly is the generation time? Guys? So let's understand one by one. Okay, now if we talk about family phases, we have 6 phases of the family. What is the first phase of the family? Marriage to the birth of child. That is going to be the formation. This is a formation. Okay, if I talk about the interval between the entry of organism till the maximum infectivity, yes, that is going to be your generation time. The interval between the primary and the secondary case, what is your answer for the primary and the secondary case? Your answer is going to be, that is called as serial interval. क्या बोलते हैं उसको? That is called a serial interval. So the interval between a primary and the secondary case is a serial interval, and the interval between the entry of infectious agent and the symptom of the disease, that is going to be incubation period. That is going to be incubation period. Okay, these are a very important definitions, my dear students. First of all, interval between marriage and the birth of a child is a formation. Interval between the entry of an organism till the maximum infectivity, that's going to be your generation time. The interval between the primary and the secondary case, that's going to be the serial interval. And the interval between the entry of infectious agent till the symptoms of disease, that's going to be the incubation period. Is that clear? Okay, so answer for the generation time is, your answer is going to be B, interval between the entry of organism till the maximum infectivity, till the maximum infectivity. Okay, now I'll ask you one more definition. Entry of an organism, entry of an organism till the detectable antibody present. What is that called as? Entry of organism, let me write it here. Entry of organism till the detectable antibody present. What will be your answer? Entry of an organism till the detectable antibody present. Answer क्या होगा? Yes, anyone in the comment section? Entry of organism till the detectable antibody present. Your answer is going to be, sir, window period. That is your window period. These all definitions are very, very, very important. They usually ask this one definition, and this generation time has been asked in the recent PG. Okay, you guys can check the recall of a NEET PG PSM. You will see that generation time was asked till the maximum infectivity. Very good. Now tell me guys, two more definitions. We have quarantine and we have isolation. We have quarantine and we have isolation. What is quarantine? What is quarantine, guys? Yes, it is a separation of it's a separation of suspected or healthy person till incubation period. Till which period, my dear students? Incubation period. And what is isolation? It's separation of disease person till period of communicability, till the period of communicability. Is that clear? All the definitions are clear, guys. Remember, window period, okay, the entry of organism till the detectable antibody present, number one. Interval between the marriage and the birth of a child is a formation. Interval between the entry of an organism till the maximum infectivity is a generation time. Interval between the primary and the secondary case is a serial interval. Interval between the entry of an infectious agent and the symptom of the disease is an incubation period. And quarantine, remember guys, the separation of a suspected or the healthy person till the incubation period. Okay, and if the separation of a diseased person till the period of communicability, it can communicate others, it can transfer disease to others, is going to be isolation. Is going to be isolation. Is that clear to everyone? Yes, is that clear to everyone? Chalo. Next, following are the primary signs in WHO classification of xerophthalmia except. So what will be your answer for this question? Following are the primary signs in WHO classification of xerophthalmia except. So what are these signs? All of these signs are the primary signs of vitamin A deficiency except. What is your answer, Gacho? What will be the answer? What will be the answer? Write down in the comment section. Yes. Following are the primary signs in WHO classification of xerophthalmia, except. Very good. Yes, Shahzad, correct. It's going to be night blindness. Night blindness is a secondary feature. Rest, corneal xerosis, corneal ulceration and conjunctival xerosis, they are going to be the primary signs, but the night blindness is going to be the secondary feature. Now let's discuss about vitamin A. Very important topic, vitamins from your exam point of view. The deficiency of a vitamin A will cause xerophthalmia. The deficiency of vitamin A is going to cause xerophthalmia. Now WHO primary signs we have. What are the primary signs? We have X1A, that is conjunctival xerosis. We have X1A, that is conjunctival xerosis. We have X1B, that is a bite-out spot. We have X1B, that's going to be bite-out spot. We have X2, that is corneal xerosis. We have X2, that is a corneal xerosis. Then we have X3A, that's corneal ulcer or the scar. Corneal ulcer or the scar. Then X3B, we have keratomalacia. We have keratomalacia. They will even ask you all of the primary features, all of the primary signs are reversible, except your answer is going to be keratomalacia. It is irreversible. Okay, primary signs may which one is irreversible? That's going to be X3B, keratomalacia. But if I talk about the primary signs which are reversible, they are all conjunctival xerosis, bite-out spot, corneal xerosis and the corneal ulcer. And if we talk about the secondary features, the first one is going to be night blindness. N, that is night blindness. Okay, then XF, that is xerophthalmic fundus. That is xerophthalmic fundus. Then XS, that is xerophthalmic scar. That is xerophthalmic scar. So this was the question asked, that out of which of the following are the primary signs except, then your answer is going to be XN, which is in secondary feature. Okay, now the first symptom of the vitamin A deficiency. What is the first symptom, guys? The first symptom, sir, is going to be night blindness. The first symptom of vitamin A deficiency is going to be night blindness. The first sign, if I talk about the first sign, that's going to be conjunctival xerosis. The first sign is conjunctival xerosis. The most common clinical sign for the screening is bite-out spot. Clinical sign most common is going to be bite-out spot. Is going to be bite-out spot. This is an exact picture of what? Bite-out spots. Okay, these keratinized epithelial cells die and they form a foamy-like structure. That is the bite-out spot. Okay, and this is a conjunctival xerosis. You can see C wave tide appearance. This is a conjunctival xerosis. The superficial epithelial cells, they cause a dryness, and giving a classical picture of a C wave tide appearance is a conjunctival xerosis. Okay, and it's bite-out spot. Chalo. The most sensitive screening test is going to be serum retinol levels. Most sensitive screening test is serum retinol level. Is a serum retinol level. And if we talk about the richest source, animal source, you have halibut oil. Richest source is halibut oil. Second richest is liver oil. And vegetables, you have carrot, and fruits mein papaya. So these are the richest source of the vitamin A. So remember, my dear students, primary signs, we have conjunctival xerosis, we have bite-out, we have corneal xerosis, ulcer and keratomalacia. All of them are the reversible, except the question can ask all of them are reversible except the answer is going to be keratomalacia. All of the following are the primary signs except either night blindness, xerophthalmic fundus, or the xerophthalmic scar. Your first symptom is going to be night blindness. First sign is in conjunctival xerosis. The most common clinical sign for the screening is a BITOTS, and the most sensitive screening test is the serum retinol levels. Now the prophylaxis. How many total doses we have? So we have 9 doses. Okay, total amount we are giving 17 lakh international units. Okay, the first dose is around 9 to 12 months. Then second to 9 dose we are giving every 6 months. We are giving every 6 months till 5 years orally. Is that clear? So this is about a prophylaxis. This is all about the prophylaxis of the vitamin A. Prophylaxis of the vitamin A. Now if a patient is having if a baby is coming to you having a deficiency of the vitamin A less than 6 months, the amount of vitamin A given is 50,000 international units. Okay, if the age is around 6 to 12 years, you have to give 1 lakh international units. If the age is more than 12 months, you have to give 2 lakh international units. And if the weight of the baby is less than 8 kg, then again 1 lakh international units. This is about the dosage of a vitamin A. And if there is a deficiency on the same day, 0, 1 and 14th day, you will give the vitamin A. Is that clear? So this was all about the vitamin A, and this is a very important from the exam point of view. They have been asked multiple times about the dosage. Okay, they can ask about this image based question, BITOT spots, okay, or about the primary sign or the secondary features. Is that clear to everyone? Yes, is that clear to everyone? Vitamin A, all of you guys, clear to everyone? Chalo, next let's discuss the other vitamins, because vitamins really are the important. Next is vitamin B1. Now vitamin B1 deficiency will cause, write down in the comment section, vitamin B1 deficiency will cause beriberi. Okay, and it's mainly seen in polished rice eaters. It's mainly seen in polished rice eaters. Okay, now in case of an alcoholics, it will cause Wernicke's encephalopathy and Korsakoff's psychosis. So let's write, in alcoholics it will cause Wernicke's encephalopathy. Okay, so how do you remember the mnemonic of the Wernicke's encephalopathy? You have to remember GOA, G-O-A. What is G? G is global confusion. G is global confusion. O is ophthalmoplegia. O is ophthalmoplegia, and A is going to be ataxia, that is Wernicke's encephalopathy. Okay, if we talk about Korsakoff's psychosis, you have to remember two things. The clinical case will give that there is a confabulation and retrograde amnesia that is about Korsakoff's psychosis. And the treatment for these two conditions, you will give IV thiamine followed by the glucose. Again, this question has been asked that during the treatment of a Wernicke's encephalopathy and the Korsakoff psychosis, what you will give prior? Will you give glucose first or the thiamine first? Your answer is to be thiamine followed by the glucose. Is that clear? And prevention, you to the parboiling of the rice. For the prevention, do parboiling of rice. Is that clear to everyone? Yes, for the prevention, do parboiling of the rice. Is that clear? So that is about vitamin B1 thiamine deficiency. Okay, now if I talk about vitamin B2, that is riboflavin. This is a classical picture of what? Beriberi. The classical picture of a beriberi. Okay, now if I talk about a second vitamin B2, that is going to be riboflavin. That is going to be riboflavin. The deficiency of the riboflavin will cause erythroplavinosis. There is a triad. What are the three things in the triad? Remember, we have angular stomatitis, we have angular stomatitis, we have chiliosis, and we have atrophic glossitis. And this atrophic glossitis is also called as geographic tongue. क्या बोलते हो और बच्चों? So it's also called as geographic tongue. You can see angular stomatitis. Okay, so vitamin B2 is a riboflavin. It causes angular stomatitis, chiliosis, and atrophic glossitis. Then we talk about vitamin B3, that is going to be niacin. The deficiency of niacin will cause pellagra. Let's be a bit quick in these vitamins because you already have studied multiple times in biochemistry as well, PSM as well. What are the features of pellagra? Okay, so write it down. What are the features of the pellagra? So we have 4 Ds. Okay, we have diarrhea, we have dermatitis, we have dementia, and we have death. We have diarrhea, dermatitis, dementia, and death. If we add a fifth D, that is going to be delirium. Okay, that is going to be delirium. If you add 6 Ds, that sixth one is going to be depression. The sixth one is going to be depression. Okay, remember 4 Ds: diarrhea, dermatitis, dementia, death, and now sixth is delirium and depression. And this is a classical picture of a Castle neck dermatitis, and is usually seen in the maize eaters. And niacin is coming from which amino acid? Niacin is coming from which amino acid? Write down in the comment section, bacho. Niacin is coming from which amino acid? Niacin is coming from which amino acid? Tryptophan. Okay, so you can also remember that it is due to the tryptophan deficiency. If the tryptophan is less, tryptophan deficiency. What are the other components coming from the, what are the other things coming from the tryptophan? Yes, what are the other things coming from the tryptophan? One is going to be your niacin. What else comes from the tryptophan? Write down in the comment section. What else from the tryptophan? Yes, biochemistry. Write down in the comment section. What else from the tryptophan? Serotonin. What else? Melatonin. Okay, so serotonin, melatonin, and niacin, they're coming from the tryptophan. Rest, epinephrine, norepinephrine, your TSH, okay, melanin, that are coming from the tyrosine. They are coming from the tyrosine. Then remember serotonin related the syndromes like carcinoid syndrome. Remember that 5-HIAA. Then the features of a patient. Okay, remember about the tyrosine disorders, like a patient has albinism, what is an enzyme deficient and all. Remember these things from the clinical biochemistry. They are very, very important. Okay, chalo. Pantothenic acid is going to be B5, and B5 pantothenic acid deficiency will cause burning feet syndrome. It will cause burning feet syndrome or soul syndrome, Soul syndrome. Okay, then vitamin B6 is a pyridoxine. The deficiency of pyridoxine will cause peripheral neuropathy. It will cause peripheral neuropathy. Along with that, it can cause microcytic hypochromic anemia. Microcytic hypochromic anemia. And peripheral neuropathy or pyridoxine deficiency is due to one drug. What is the name of the drug which causes a pyridoxine deficiency? What is the name of the drug which causes pyridoxine deficiency? Yes, it's an anti-TB drug. What is the name of the drug? Isoniazid. What is the name of the drug? It's due to the side effect of a drug, isoniazid. It's due to the isoniazid. That's why it is mandatory whenever a patient is on the anti-TB drugs, we along with that prescribe isoniazid in order to prevent the peripheral neuropathy. Okay, remember the side effects of all the TB drugs. Let me recall. If we talk about ethambutol, that causes an optic neuritis. Ethambutol causes optic neuritis. Pyrazinamide causes hyperuricemia, gout. Okay, pyrazinamide causes hyperuricemia, gout. Okay, remember streptomycin causes ototoxicity. Rifampicin causes orange color secretions. And isoniazid causes peripheral neuropathy. If I talk about a new drug, bedaquiline, that causes a QT prolongation. Is that clear? Is that clear to everyone? Chalo. Next one is B7. The deficiency of a vitamin B7 biotin will cause alopecia. Okay, it will cause a hair loss. Okay, the exclamatory sign, a patchy hair loss. What is your diagnosis? Exclamatory sign with a patchy hair loss. What is your diagnosis? Which type of alopecia? That's going to be alopecia areata. What is that? Alopecia areata, exclamatory sign. And alopecia areata, what is your drug of choice? Alopecia mein drug of choice is? What will be your drug of choice in alopecia areata? Yes, raw egg. Very good. Raw egg consumers will also have biotin deficiency. Okay, what will be your treatment for the patient having alopecia areata? Sir, minoxidil. Okay, we give minoxidil 5% in males and 2% in the females. Along with that, we also give drug finasteride, which is a 5-alpha reductase inhibitor. Chalo, ठीक है ना? Minoxidil 5% in males, 2% in females. Along with that, we also use finasteride, which is a 5-alpha reductase inhibitor, which will prevent the conversion of a testosterone to the dihydrotestosterone. Okay, next is going to be the folic acid. Vitamin B9. You already know vitamin B9 deficiency will cause megaloblastic anemia. It will cause megaloblastic anemia. Okay, and along with that, in pregnancy, you already know, in pregnancy, the folic acid deficiency will cause neural tube defects. Okay, in pregnancy, it will cause neural tube defects. Is that clear? Now, if we talk about vitamin B12, the deficiency of vitamin B12 will cause, again, sir, it will cause megaloblastic anemia. Second one, it will cause the subacute degeneration of myelin. Okay, and this vitamin B12 deficiency, it is seen in strict vegetarians. Okay, that is cyanocobalamin. Now, sir, a patient having a B9 deficiency and a patient having a B12 deficiency, both of them have what? Which anemia? megaloblastic anemia. Now if I ask you how do you differentiate this megaloblastic anemia as per the clinical features, what will be your answer? Anyone in the comment section? Now you already know from the investigation, from the biochemistry point of view, you will either check MMA levels and a homocysteine levels. Okay, now tell me, in case of a yes, if a patient is having ileostomy, okay, terminal ileum resection, again the vitamin B12 will be not absorbed, so patient will have B12 deficiency as well. Okay, but my question is that if a patient is having a B12 deficiency or a patient is having a megaloblastic anemia, as per the clinical features, how you will differentiate? How you will differentiate? As per the clinical features, how you will differentiate? Both increase in the B12, yes, both will increase in the B12, but as per the clinical features, tell me, anyone, as per the clinical features, how you will differentiate a patient having a B9 deficiency and the B12 deficiency? B9 and B12 deficiency as per the clinical features. Yes, patient of B12 will have a neurological deficit features because B12 helps in the formation of a myelin sheath. Okay, and the myelin sheath is not formed properly. What will happen? Neurological deficit features will come. That's why it causes subacute degeneration of the myelin. As per the clinical feature, that's how we differentiate. But if case of a biochemistry point of view, if we talk about a B12, both will be elevated. Okay, let me write. Okay, and here in folate, MMN levels will be normal, homocysteine levels will be elevated. Is that clear? Is that clear? So MMA levels if and homocysteine levels, if they are increased, that's suggestive of a B12 deficiency, and if MMA levels are normal and homocysteine levels are elevated, that's suggestive of a folate deficiency. Is that clear? Is that clear? Yes, only homocysteine levels in folate. Remember that both are increased. B for B12. Okay, B12, both are increased. That's going to be B12 deficiency, and if only one of them is increased, then it's going to be the folate deficiency. Is that clear? Now sir, vitamin C, ascorbic acid. Okay, the deficiency will cause scurvy. The deficiency will cause scurvy and delayed wound healing The deficiency will cause scurvy. Also it can cause gum bleeding. Okay, and the richest source if we talk about, that is amla, which is also called as Indian gooseberry. Okay, this is a classical picture of a scurvy. This is a classical picture of a scurvy. Okay, now my question to you guys, this is a folic acid deficiency, spina bifida. Okay, and the two signs in spina bifida you already told me, I've already mentioned, lemon sign and the banana sign. Spina bifida, most common type of spina bifida, your answer is going to be spina bifida occulta. Your answer is going to be spina bifida occulta. Is that clear? And how we exactly check the neural tube defects in case of pregnancy? What do we check in an amniotic fluid? Your answer is going to be acetylcholinesterase in the amniotic fluid is a suggestive of a neural tube defect. Now my dear students, tell me which drug causes gingival hyperplasia, gingival hypertrophy? Which drug causes gingival hyperplasia or gingival hypertrophy or gingivitis? Which drug causes gingivitis or gingival hypertrophy? Not alpha fetoprotein, it is acetylcholinesterase in amniotic fluid. That's such suggestive of a neural tube defect. Okay, now which drug will cause a gingival hypertrophy or gingivitis? Gum hypertrophy. Phenytoin. Very good, the drug is going to be phenytoin. What is the name of the drug? The drug is going to be phenytoin. Okay, chalo. Vitamin D, the most active form. Now vitamin D has subtypes: vitamin D1, D2, D3, D4 and D5. But D2 and D3 are a physiological important: ergocalciferol and cholecalciferol. What are D2 and D3? Ergocalciferol and D3 cholecalciferol. The most active form is going to be calcitriol. The most active form is going to be calcitriol. That's 125 dihydroxy cholecalciferol. 125 dihydroxycholecalciferol. The deficiency of vitamin D in children's, will cause rickets. In children's it will cause rickets. In adult it will cause osteomalacia. Then क्या होगा patient को? Osteomalacia and osteoporosis. Again, the richest is halibut liver oil. The natural is sunshine. Okay, remember vitamin D and B12. There is no plant source. ठीक है ना? चलो, vitamin D most active form is calcitriol, 125 dihydroxycholecalciferol. We have D2 and D3 physiological important. D2 is your ergocalciferol and D3 is cholecalciferol. Deficiency in children is going to cause rickets. Okay, deficiency in children is going to cause rickets. In adults it will cause osteomalacia and osteoporosis. And the richest source is halibut liver oil. The richest source is going to be halibut liver oil. Okay, vitamin E is tocopherol. Write it down. It is an antioxidant, most potent antioxidant. What is your answer? So the answer is going to be vitamin E. Most potent antioxidant is vitamin E. The richest source is wheat oil. And the deficiency of vitamin E will cause hemolytic disease of newborn. It causes hemolytic disease of newborn. Okay, it also causes ophthalmoplegia. So that is about vitamin E. That's about vitamin E. Vitamin E, it's an antioxidant. Okay, it causes the hemolytic disease of newborn and it causes the ophthalmoplegia. Followed by that, vitamin K. Vitamin K deficiency will cause hemorrhagic disease in newborn. Hemorrhagic disease of newborn. It causes hemorrhagic disease of newborn. Okay, now we have forms of vitamin K. We have a natural form and the synthetic form. We have a natural form which is a fat soluble. It's a fat and synthetic form, it is water soluble. If you talk about natural form, K1, that is phylloquinone. And K2, that is menaquinone. And K3, it is menadione. Is that clear? In infants, vitamin K deficiency, and in adults it can cause bleeding. Is that clear? Followed by that, we have selenium deficiency. Selenium deficiency will cause, yes, comment section mein batao, selenium deficiency will cause. Your answer is going to be selenium deficiency will cause endemic cardiomyopathy called as Cashion's disease. Endemic cardiomyopathy. Okay, that's called as Cashion's disease. And if there is excess selenium, that is a Cashion's back disease. If there is an excess selenium. Okay, the zinc deficiency will cause acrodermatitis enteropathica. It will cause acrodermatitis enteropathica. It will also cause delayed wound healing. It will also cause delayed wound healing. So acrodermatitis enteropathica and delayed wound healing are the features of zinc deficiency. And patient of zinc deficiency, along with that, what will a patient have? Patient will have diarrhea, dermatitis as well. Is that clear? So this is about selenium deficiency and zinc deficiency, and this is a classical picture of acrodermatitis enteropathica. Acrodermatitis enteropathica. Is that clear? We have one more element, guys, fluorine. If there is an excess of fluorine, that will cause dental fluorosis. Remember that. If there is decreased fluorine, that will cause dental caries. Then the one question in your exam was asked, what is the level of a fluorine which will cause a crippling? That is more than 10. Okay, so that was all about the vitamins and minerals. Is that clear to everyone? Okay, vitamins are clear. Remember, your PYQ was asked about the vitamin D. Vitamin D causes laryngismus stridulus, that is your laryngospasm. ENT mein this exam question, it causes laryngospasm. Which vitamin deficiency will cause laryngismus stridulus, that is laryngospasm? Your answer is going to be vitamin D. What will be your answer, bacho? The answer is going to be vitamin D. Is that clear? Is that clear? Is that clear to everyone? So this is all about vitamins. This is all about vitamins. Yes. Let's, any doubts from the vitamins? All clear, bacho? Yes, all clear? Chalo, good. Yes. Chalo. A patient with a 3 hypopigmented anesthetic patch with a 1 thickened nerve presents to your OPD. What shall be your treatment approach? So a patient with a 3 hypopigmented anesthetic patch. So anesthetic patch mentioned, nerve is involved. Your classical diagnosis, you know, it's a leprosy. Now, which type of leprosy is that? Comment down the answers. Which type of leprosy is that, and what will be your treatment regimen? What will be your treatment approach? चलो बता दो जल्दी से, which type of leprosy and what will be your treatment approach? Okay, so let's discuss about the types of leprosy. First, we have two types as per the WHO classification. We have two types. We have paucibacillary and multibacillary. In paucibacillary, the number of lesions we have 1 to 5, and in multibacillary, number of lesions we have more than 5. We have more than 5. Okay, if we talk about the treatment, we have 3 drugs. So we have dapsone, we have rifampicin. So we have dapsone, we have rifampicin, and we have clofazimine. We have dapsone, we have rifampicin, and we have clofazimine. And in multibacillary, we have same 3 drugs. Now, my dear students, now my question to you guys is, which of the following is the most potent drug in leprosy out of these 3 drugs? If I mention dapsone, rifampicin, and clofazimine, which of the following is the most potent drug in leprosy? Which of the following is the most potent drug in the leprosy? What will be your answer? Which of the following is the most potent drug in the leprosy? What will be your answer? Which of the following is the most potent drug in the leprosy? The oldest one is the dapsone. The oldest one is going to be your dapsone. Which of the following is the most potent one? The answer is going to be rifampicin. This can be asked the question. Rifampicin is the most potent drug in case of treating leprosy. Is that clear? Chalo. Next. After that, if we talk about the duration of the treatment, in case of a paucibacillary, that's for the 6 months. That is for the 6 months. Okay, and for the multibacillary we have 12 months. Okay, multibacillary we have 12 months. Okay, follow up here yearly for 2 years, and here yearly for 5 years. So you have 3 hypopigmented patches. It is a case of a which leprosy? It's a paucibacillary leprosy. So what will be your answer, bacho? So 3 drug for how long? 3 drugs for how long? 6 months. Your answer is going to be C. 3 drugs regime for how many months? For 6 months. For the 6 months. Is that clear? Is that clear? What will be your answer? C. 3 drug, that is rifampicin, dapsone and clofazimine. For how many months? 6 months. Now my question to you guys, if you have a patient coming to you who has a resistance for rifampicin, what is the drug, what is the treatment for a resistant treatment for the leprosy? Patient is coming to you, patient has a resistance to the rifampicin, what will be your treatment? What will be your treatment? What is the treatment you will give? What are the drugs that are given for a rifampicin resistance in leprosy? I'm writing here, if resistance to rifampicin, the drug given is clarithromycin and minocycline. The drug given is clarithromycin and minocycline. The drug given is clarithromycin and minocycline. Is that clear to everyone? Is that clear to everyone? Clarithromycin and minocycline. Is that clear to everyone? Yes, remember that. Now if we mention, we have one more classification called as Ridley-Jopley classification. Okay, we have one more classification called as RJC classification. यहाँ पे आएगा हमारा tuberculoid and borderline tuberculoid, and over here we have BB, borderline lepromati and lepromatous leprosy. Okay, this is called as a Ridley-Jopley classification. Okay, now if we talk about the most common nerve involved, what is your answer, bacho? Most common nerve involved. And second one, most common cranial nerve involved. Most common nerve involved and most common cranial nerve involved. The most common nerve involved is going to be your ulnar nerve. That's your ulnar nerve. And most common cranial nerve involved, that's your facial nerve. That's your facial nerve, ulnar nerve and the facial nerve. Okay, next if I talk about the lepra reactions, we have type 1 lepra reaction and we have type 2 lepra reaction. Type 1 lepra reaction and type 2 lepra reaction. Okay, remember the rule of 5. Okay, what you will add to 1, it will become 5, 4. So hypersensitivity type 4 reaction, and type 2 is hypersensitivity 3. Okay, remember type 1 lepra reaction, we have 4, and here we have type 3 hypersensitivity reaction. Is that clear? Ulnar and facial, very good. Then type 1 is 4, type 2 is 3. That is going to be lepra reaction, and this is called as rule of 5. Again a PYQ, rule of 5. So this is all about the leprosy. Okay, this is all about the leprosy. Is that clear? Now this is a logo for National Elimination Program for Leprosy, National Elimination Program of Leprosy, NLEP, and it's already eliminated. Leprosy is already eliminated December 2005. Okay, this is a Sapna, our campaign mascot. It gives awareness about a leprosy. This was a NEET PG question that was asked. Sapna had once a leprosy, she's cured, now goes under the spread awareness about the leprosy. My dream is to see a leprosy free India, says Sapna. Okay, and this was the image that this girl is having a campaign for which disease? Your answer is going to be leprosy, and this logo is for the Yes, thalidomide. Abhi, very good. Type 2 lepra reaction, the drug that we use for the treatment is thalidomide. Lepra reactions mein drug we use is thalidomide. Okay, thalidomide. And remember, thalidomide in pregnancy will cause abnormal limbs. Okay, it will cause abnormal limbs if used in pregnancy. Your answer is going to be phocomelia. Okay, now remember, yes, lepra reaction mein drug kya dete, thalidomide dete. And second thing is, if you use this in pregnancy, that causes phocomelia, abnormal limbs. Next is going to be the NLEP, flower, remember, National Elimination Program. Second one is SAPNA for leprosy. The second one is SAPNA for leprosy. Then the National Tuberculosis Elimination Program says that will eliminate TB by 2025. Okay, but it's not possible. As per the Sustainable Goal Development, SGD says we will reduce the cases by 90% by 2030. Okay, that is the TB data. Remember the two updates from the TB. Remember the incentives as per the DOTS. Incentive as per the DOTS therapy they give now. Before it was 500 rupees per patient per month. Now it's 1000 rupees. And we have a new regime for the tuberculosis. Called as B-PAL-M regime. Okay, before it was B-PAL only. Okay, before it was B-PAL only. B for bedaquiline, P for pretonamide, and L was linezolid. But recently one more has been added, that is M. And remember, they can ask you the question in a new regime of tuberculosis, that is B-PAL-M regime. The M stands for, your answer is going to be moxifloxacin. Is that clear to everyone? So DOTS mein number 1, incentives are given ₹1000, sir. B-PAL-M regime, M is moxifloxacin. One more update in the part 1 of PSM, I have mentioned about the Suraksha Clinic kits. The kit 1 I mentioned anorectal discharge, but now there is a one more new kit, that is going to be kit 8. I'm writing here, that is going to be kit 8, which is brown color. Kit 8, which is brown color, for anorectal discharge. If in case more updates, I'll update in my channel about the PSM updates. Okay, but for now, recent kit 8 is a new update, incentives ₹1000 is a new update, moxifloxacin in September is a new update. So out of these three things, they can ask one thing. Okay, we are expecting एक चीज तो पूछेंगे ही, ठीक है? चलो next question. Is that all clear? All clear about the leprosy? Write down in the comment section, guys. All clear about a leprosy? Everyone out there? Yes, are you understanding well? Speed is okay? Chalo. Next. One of the methods of a health communication where 4 to 8 persons are qualified to talk about the topic. Qualified to talk about the topic and discuss a given problem or the topic in front of a large group or audience in sequence. What is the method called? So 4 to 8 people are delivering in front of an audience with a correct order of speech. What will be the method called as? So you already know Socratic and didactic method. Write down in the comment section what will be the answer for this, bachcho. What will be the answer for this? Sir, the drugs for kit 8, write it down: cefixime and doxycycline. Cefixime you give 800 mg start and then doxycycline. Cefixime and doxycycline for the kit 8 abhi. But Gray was anorectal, now it's a new update 8. Now kit 8 is there. Before it was only 7 kits, Hema. Okay, now we have 8 kits. The 8th one is a brown color, which is usually for the anorectal discharge. The two medications are cefixime and doxycycline. Okay, cefixime and doxycycline. Cefixime 800 mg start, followed by doxycycline 14 capsules twice a day for a week. Is that clear? Is that clear to everyone? Chalo. So what will be the answer for this? One of the methods of health communication where 4 to 8 persons are qualified to talk about the topic and discuss a given problem in front of a large group or audience in a sequence. So when there is a correct order of speech, correct order of sequence when you are delivering, the method is called as, what will be your answer, bacho? The method is called as, let's discuss first of all, sir, focus group discussion. First of all, let's discuss what is focus group discussion. It's discussion among 6 to 12 person. It's discussion among 6 to 12 person. There is one group leader, there is one recorder, and it's a two-way process. It's a two-way process. Followed by that, we have a panel discussion. In panel discussion, it's a discussion among, the panel discussion is a discussion among 4 to 8 experts in front of audience. 4 to 8 experts in front of audience. For example, the classical examples are news channel, okay. And then remember, there is no correct order of speech, or there is no correct sequence. There is no specific order of speech. There is no specific order of speech, okay. That is your panel discussion, okay. The next one is a symposium. It is same like a panel discussion, but the only difference is there is a correct order of speech. So write it down, discussion among 4 to 8 experts. Discussion among 4 to 8 experts in front of audience. In front of audience, okay. Then it's a two-way process. It's a two-way process with correct order of speech. There is a specific order of speech. There's a two-way process with a specific order of speech. Then we have a method of communication, one more, called as demonstration, which has a principle of, write it down, demonstration. Learning is like seeing is believing, learning by doing. Seeing is believing, learning by doing. For example, we do a demonstration for ORS. We do a demonstration for ORS. Brown. Now it's an update. Before it was gray only, but the new update is you need to choose what? You need to choose brown for anorectal discharge now. Okay. Chalo. Spikes technique. In order to break the bad news, we use a technique called as spikes technique. It has a protocol of 6 steps, okay. Now after this, come back to the question. Now you have a 4 to 8 experts. They are delivering in front of an audience with the correct order of speech. What is your answer, bacho? What will be the answer? You have a people, 4 to 8 experts. They are delivering in front of an audience with a correct order of speech. What will be your answer? What will be your answer? Write down the answer now. What will be the answer? With a correct order of speech, the answer is going to be symposium. Sir, panel discussion. there is no sequence or there is no correct order of speech. Now can you tell me what is the most effective method of communication? Your question. Most effective method of communication. What is the most effective method of communication, bachcho? Your answer is going to be, what will be your answer? Most effective method of communication. Your answer is going to be most effective method of communication, interpersonal communication, IPC. That is interpersonal communication, one-on-one, face-to-face. Okay, that's the most effective method of communication. Okay, remember guys, this spikes technique is a protocol of 6 steps. S stands for the set up the interview, P is perception, then you have I, invitation to explain, then you have K, knowledge, you will explain, then E, emotions, and S is going to be summary or strategy. So in order to break the bad news, you will use a technique called as spikes technique. Now my question to you guys, gather approach or the cafeteria approach is used for? Gather approach or the cafeteria approach is used for? Again, the previous year question, my dear students, gather approach or a cafeteria approach is used for? Write down in the comment section. Gather approach or the cafeteria approach, it's used for? Gather approach or the cafeteria approach is used for? What will be the answer? Gather approach or the cafeteria approach? Contraception counseling. Okay, remember that these things are important. Contraceptive counseling, yes Sabhi, very good. Contraceptive counseling, these are important stuff guys. Then remember the gather, greet, ask, okay, tell, help, explain, and return. For the contraceptive counseling, we have a cafeteria approach or the gather approach. Chalo. The best parameter for the assessment of an acute malnutrition is? The best parameter for the assessment of acute malnutrition is? What will be your answer? The best parameter for assessment of acute malnutrition is? What will be your answer? Chalo, let me discuss about this. If we talk about the low weight for age, if it's a decreased weight for age, that is acute plus chronic undernutrition or underweight, that is going to be underweight, acute plus chronic undernutrition. Acute plus chronic undernutrition. If we talk about decreased weight for height, that is acute malnutrition. That is acute malnutrition, which is also called as wasting. Wasting. Okay, and if there is a decreased height for age, that is going to be chronic malnutrition. That is going to be chronic malnutrition. It's also called as stunting. It's also called as stunting. Okay, so the simple question was asked, the best parameter for the assessment of acute malnutrition. So for the acute malnutrition, what will be your answer, bacho? Your answer is going to be B, that's weight for height. That's weight for height. The answer is going to be B, weight for height. Okay, if I talk about weight for age, that is underweight, sir, acute plus chronic. If I talk about height for age, that's the chronic malnutrition stunting. Okay, now let's understand the two malnutrition disorders, Kwashiorkor and marasmus. Kwashiorkor and marasmus. If I talk about Kwashiorkor, my dear students, it develops in the children who are deficient, whose diet is deficient of proteins. But marasmus, it is proteins and calories. Okay, it occurs in the children between the 6 months and 3 years. Okay, and it's under 1 year. Marasmus usually occurs patients under 1 year. Okay, The subcutaneous fat is preserved in Kwashiorkor, whereas subcutaneous fat is not preserved, due to which you can see the patient is having, a baby is having a prominent ribs. Ribs are exactly seen. Then edema is present, edema is absent. So there is edema, there is enlarged fatty hepatomegaly, there is splenomegaly seen in the patient of a Kwashiorkor. Okay. Ribs are not very prominent. Ribs are very prominent because there is no subcutaneous fat over there. Baby is lethargic, here it's alert and irritable. Muscle wasting is mild, here is muscle wasting is more. There is poor appetite, here it's a voracious feeder. Okay, the person suffering from the Kwashiorkor needs adequate amounts of proteins, and here he needs carbs, fats and proteins. Okay, this is a classical picture. You can see a protuberant belly, protruded belly out there. Okay, you can see hepatomegaly. You can what you have to remember, there is a cirrhosis, poor wound healing, itchy rash. It's a Kwashiorkor, or they will mention in the clinical case hepatomegaly and the splenomegaly. Okay, one more thing about a Kwashiorkor you will remember, guys, there's a classical sign in the hair. For example, if this is a hair shaft, it is white, then black, then white. This is called as flag sign. This is called as flag sign. Okay, this is called as flag sign, seen in Kwashiorkor. Okay, and over here this is an old man face. Old man face seen in marasmus. Okay, the marasmus is kind of mara hua. Okay, prominent bones, there is decreased subcutaneous fat and the loose skin. So remember the differences between Kwashiorkor and the marasmus. Hepatomegaly, edema, splenomegaly. Okay, flag sign is going to be Kwashiorkor, protein deficient. Protein and calorie both is going to be marasmus. Chalo, next question. Remember, guys, the weight for age is underweight, weight for height is acute malnutrition, height for age is chronic malnutrition, underweight, wasting and stunting. Next question is going to be from the rabies, very important. What is the recommended vaccination schedule for the post-exposure prophylaxis for the rabies in a previously vaccinated individual? So you have a patient coming to you who is already vaccinated for the rabies. Now what will be your vaccination schedule for someone who is already vaccinated 6 months back? Write down the comment section. Option A, you will go for the full course of the anti-rabies vaccine plus rabies immunoglobulin. You will go for the wound cleaning ARV on day 0 and 3, wound cleaning on the day 0, 3, 7, and none of the above. What will be your answer? Write down the answer in the comment section, everyone. Yes, write down your answers. What will be the rabies vaccination schedule in a patient who has been already vaccinated, who is previously vaccinated? No silly mistakes. Shazad, what will be the vaccination schedule? Okay, now let me discuss about, first of all, the dog bites. We have 3 grades, grade 1, grade 2 and grade 3, or class 1, class 2 and class 3. Class 1, it's just a lick or the unbroken. What you have to do is you have to wash sorry, what you have to do is you just have to wash it with extensively with the soap and water for the 15 minutes. Class 2 or the grade 2 is the scratching but without the blood. You will go with the local wound management plus the vaccination. Class 3 is a multiple scratch, loosening of the blood, laceration or the abrasions or unknown wild dog. So there is a oozing of the blood is coming out with a multiple scratch. That's going to be grade 3 bite. Okay, class 1, class 2 and class 3. Now rabies vaccination schedule, if a patient is a pre-exposure prophylaxis, patient have a dog and he wants to get vaccinated prior to the bite, before the bite. Remember, pre-exposure prophylaxis, that is before bite. So what is the prophylaxis? It's day 0, it's 7, 21 or 28. So pre-exposure prophylaxis, day 0, day 7, okay, day 0, day 7, 21 or 28. Okay, post-exposure prophylaxis, if he is not vaccinated, post-exposure prophylaxis, not vaccinated after bite. After bite, you have two regimes. You have SN regime. You have SN regime, and the next one you have Thai updated Red Cross regime. You have Thai updated Red Cross regime. Okay, my dear students, if we talk about SN regime, it's intramuscular you're giving. So what are the days you will give? 0, 3, 7, 14 and 28. You are giving 0, 3, 7, 14, 28. That is going to be your SN regime. That's going to be your SN regime. Okay, if I talk about Thai regime, that's intradermal you will give. Okay, you are giving 0, 3, 7 and then 28. 0, 3, 7 and then 28. Is that clear? Is that clear? Intramuscular and intradermal SN regime and Thai updated Red Cross regime. And post exposure if he is coming after a bite. Post exposure if he is coming after the bite. So how do you remember? If it is less than 3 months, if it's already vaccinated less than 3 months, wash the wound. Wash the wound. Okay, more than 3 months, you will go with day 0 and 3. You will go with day 0 and 3. Is that clear? So here, what will be your answer, guys? What will be the answer? Previously vaccinated, your answer is going to be wound cleaning plus ARV on day 0 and 3. Wound cleaning plus ARV on day 0 and 3. Is that clear? Is that clear to everyone? Yes. Then we also use the serum around the wound, okay, by 20 international units per kg, and left off the above you go with the deltoid muscle, buttocks mein dete. Is that clear? Anti-rabies serum. Okay, they will not ask you that, they will just ask you about the schedule. Remember, pre-exposure, post-exposure in vaccinated and not vaccinated. Clear to all of you guys? Yes. What are the intracytoplasmic inclusion bodies seen in rabies? Okay, rabies is caused by, what is the name of the virus? Virus ka naam? Anyone? In the comment section. Yes, the virus name is Lissa virus. From the microbiology, what is the shape of the virus? Bullet shaped. Then one more, intracytoplasmic inclusion bodies. So what are the bodies called as? Negri bodies. What is the first site? What is the first site to be found? Horn of hippocampus. Horn of hippocampus. Second is going to be cerebellum. Second is going to be cerebellum. Lissa virus, Negri bodies, horn of hippocampus, and they usually have a hydrophobia. Patients of rabies, they have a hydrophobia. Rabies has a case fatality rate of 100%. Which disease has a case fatality rate of 100%? That is going to be rabies. Is that clear to everyone? Rabies has a case fatality rate of 100%. Intracytoplasmic inclusion bodies are going to be Negri bodies. First site is going to be horn of hippocampus, followed by that. Second one is going to be cerebellum. Is that clear? Name of the virus is Lissa virus. The shape of the virus is bullet shaped. Then the vaccination schedule, in the pre-exposure prophylaxis we have 0, 7, 21 or 28. Post exposure in a vaccinated, not vaccinated person, if SN regime, we are going with 0, 3, 7, 14, 28, and Thai updated we have 0, 3, 7, 28. Yes, Shazad, right. Okay, is that clear? And if a patient is already vaccinated less than 3 months, wash the wound. More than 3 months, day 0 and 3. Day 0 and 3. Okay, we also use anti-rabies serum directly around the wound, will give maximum, and the left you give in the buttocks. Is that clear? Is that clear to everyone? Rabies is very, very important from the exam point of view. I hope it's all clear. Yes, can we go ahead? Chalo. A 50 very important question, rabies, and the coming up very important question, because HIV increasing in India, and usually they ask from the chapters which are common disease in India. So the 50-year male presented in a medical emergency with a complaint of a fever, headache. On examination, there is a neck rigidity as seen. Investigation confirms a case of HIV with cryptococcal meningitis. What is the possible CD4 count at which this opportunistic infection, that is cryptococcal meningitis, will take place in a AIDS patient? So my dear students, you already know that AIDS is an immunocompromised. When a patient is having AIDS, it's an immunocompromised state. And when a patient is in an immunocompromised state, there are more chances of opportunistic infections, and the opportunistic infections will be starting based upon the CD4 count. Okay, now tell me, what are the opportunistic infections at CD4 count? Yes, good answers. What are the opportunistic infections seen in AIDS patients, and irrespective of the CD4 count, what are the infections? First of all, if I talk about more than 500, what are the opportunistic infections seen? None. Okay, now cryptococcal meningitis is seen. When a CD4 count is very good, it is 200 to 100. Okay, that is going to be your option C. Okay, now let's discuss about all these opportunistic infections and the treatment of these. If we talk about more than 500, there are no opportunistic infections. If the CD4 count is between 500 to 200, what will be your answer? So first of all, tuberculosis, then pneumocystic girovacin pneumonia, followed by that PJV will be between 200 to 100. So tuberculosis, second one is going to be candidiasis, and third one is going to be Kaposi sarcoma. Okay, if the question mentions most common opportunistic infection, seen in a patient of HIV AIDS, your answer is going to be tuberculosis. Okay, most common opportunistic infection in India in a patient having AIDS is tuberculosis. Outside India, it's pneumocystic girovacin pneumonia. Okay, between 200 to 100, your answer is pneumocystic girovacin pneumonia, PJP. Okay, and what else? We have cryptococcal meningitis. Okay, followed by that, if a CD4 count is between 100 to 50, the opportunistic infection that is seen is toxoplasmosis. Okay, and if it is less than 50, we have CMV retinitis, and we have Mycobacterium avium complex. Okay, so remember all the opportunistic infections, guys. If it's between 500 to 200, it's tuberculosis, candidiasis, Kaposi sarcoma. If it's 200 to 100, it's pneumocystic girovacin pneumonia and the cryptococcal meningitis. If it's 100 to 50, it's toxoplasmosis. If it's less than 50, that's going to be your CMV retinitis or Mycobacterium avium complex. Okay, now what exactly are these? This is an MRI of a patient having a cerebral toxoplasmosis. What is your diagnosis? Cerebral toxoplasmosis. Don't confuse it with neurocystic cirrhosis. I know neurocystic cirrhosis have a same appearance, okay, starry sky appearance, but in neurocystic cirrhosis, these dots will have a one more dot like this. Active larva will be seen. Okay, but here this is all only what? Multiple eccentric dots. What are these? So they are multiple eccentric dots. Okay, these multiple eccentric dots are seen in cerebral toxoplasmosis. What is a triad of a toxoplasmosis? Remember HCC. We have hydrocephalus. Second one, we have chorioretinitis. And third one, we have intracranial calcification. cranial calcification. So my dear students, AIDS patient, AIDS positive patient coming to you with a complaint of a seizure. Clinical feature क्या होगा? Mainly patient is having seizures. Okay, along with that hydrocephalus, chorioretinitis. One of the finding is mentioned. Your answer should be going to what? Your answer is cerebral toxoplasmosis. Cerebral toxoplasmosis. So what is the treatment for toxoplasmosis? We give 3 drugs. We give leucovorin. Very good. HCC is a tried, but the 3 drugs that we give leucovorin, we give pyrimethamine, and we give sulfazidine. Okay, leucovorin, folinic acid, pyrimethamine, and sulfazidine. And in case of a pregnancy, if they mention what is the treatment for the toxoplasmosis, your answer is going to be yes, your answer is going to be spiramycin. Your answer is going to be spiramycin. Is that clear to everyone? Is that clear to everyone? That is about a cerebral toxoplasmosis. If you talk about cryptococcal meningitis, your drug of choice is going to be L-amphotericin B. Cryptococcal meningitis, my drug of choice is going to be L-amphotericin B lab. Okay, CSF test with the ink called as India ink. LISA भी करते हैं, India ink से भी करते हैं. Is that clear? Then the next one is a pneumocystic girovacin pneumonia, guys, PJP. Okay, the drug of choice for pneumocystic girovacin pneumonia, okay, is clotrimazole. For the prophylaxis as well as a drug of choice. Second thing, you will remember that this pneumocystic girovacin pneumonia, my dear student, there is a classical stain that we use, Gomory methamine silver stain, GMS stain, that is Gorot's. Okay, Gomory methamine silver stain, that is in case of a pneumocystic girovacin pneumonia. On chest x-ray, third finding in the chest x-ray, you will remember there are perihilar opacities seen. That is all about pneumocystic girovacin pneumonia. Is that clear? Very good. Is that clear? Next one, the malignancies with HIV. What are the malignancies with HIV? Number 1 is going to be Kaposi sarcoma. Second one is going to be cervical cancer. Third one is going to be non-Hodgkin's lymphoma. The most common one is going to be non-Hodgkin's lymphoma. Some books say Kaposi sarcoma, but most common one is going to be non-Hodgkin's lymphoma. Now this picture that is given, the fundoscopic picture, okay, as you can see, there is a pizza pie appearance. Along with that, there are spots called as cotton wool spots. These spots are called as cotton wool spots. So the fundoscopic picture of a pizza pie appearance and the cotton wool spot is a diagnosis of a CMV retinitis. Again a PYQ, CMV retinitis. What is your drug of choice? It's going to be, very good, what is drug of choice? Is going to be Jancyclovir. Remember, the drug of choice for CMV retinitis is going to be Jancyclovir. What will be the drug of choice for CMV retinitis? That's going to be Jancyclovir. Followed by that, this is going to be the malignancy associated, the tumor of a skin mucous membrane called as Kaposi sarcoma. Associated with HHV8. And what will be the treatment for Kaposi sarcoma? We have surgery plus chemotherapy. Surgery and chemotherapy. This was all about the opportunistic infection in a patient of AIDS. Now, if a baby is having AIDS, if a mother is having AIDS, what are the prophylactic 2 drugs that will start in a patient? If a mother is AIDS positive, what are the prophylactic drugs you will start? You will start 2 drugs called as nevirapine and zidovudine. 6 weeks to 18 months. Minimum of 6 weeks up to 18 months it can go. Is that clear? Okay, neck rigidity, headache and fever, cryptococcal meningitis. CSF test we do with the India Inc. Drug of choices L-amphotericin B. Pneumocystic jirovecine pneumonia, GMS, clotrimazole, perihilar opacities. Hydrocephalus, chorioretinitis and intracranial calcifications are the classical triad for, and the clinical features of seizure are the classical triad of cerebral toxoplasmosis. Is that clear? Then pizza pie appearance and cotton wool spots on the fundoscopy. These findings are suggestive of CMV retinitis. Drug of choice is going to be Jan-cyclovir. Drug of choice is going to be Jan-cyclovir. And HHV8 is a Kaposi sarcoma. The treatment is surgery and chemotherapy. The treatment is surgery and chemotherapy. Is that clear? Is that clear to everyone? Is that clear to everyone? Let's move to the next question, guys. Under the ESI Act, sickness benefit is given a period of. Under a ESI Act, the sickness benefit is given for the period of. Write down the answer in your comment section, guys. Yes, very correct. The answer is going to be 91 days. The answer is going to be 91 days. Now let's discuss about the ESI Act. ESI Act is an employee state insurance act which includes all the industries and areas. Okay, except, you will remember, except railways, mining and defense. Except railways, mining and defense. Except railways, mining and defense. Okay, now if we talk about the facilities as per this ESI Act, there is a free medical care, worker plus family, inpatient department and the outpatient department. The sick leave is given for 91 days. The sick leave is given for 91 days or 3 months, and 70% of salary will be given. The salary given is 70%. If I talk about extended sick leave, it's up to 2 years, and the salary will be given as 80% of the salary, and the salary given is 80% of the salary. If I talk about a maternity leave, that is up to 6 months. Maternity leave is given up to 6 months, and the salary is 100% of salary. The salary given is 100%. If we talk about enhanced leave for the vasectomy, 7 days. 7 days leave for the vasectomy. Tubectomy, 14 days. Tubectomy is 14 days. The disability benefits for the temporary is leave till recovery. If it's temporary, he'll get a leave till a recovery, and that is 100% of salary will be given. And if there is a permanent disability, then a pension as per the guidelines will be given. Pension as per guidelines. Then the pension as per the guidelines will be given. And if we talk about the funeral benefits, that is 15,000 per month. Sorry, the funeral benefits, that is 15,000 rupees. This is the logo of an ESIC, that is Employee State Insurance Act. Okay, and how much employee? In case of employee, my dear students, 0.75% of wage, and in employer, that is 3.25% of wage. So simple question was asked about the sickness benefit is given a period of, the answer is going to be 91 days. That is ESIC. Remember, extended sickness for 2 years, 80% of salary. Sickness, 70% of salary. Maternity, 100% salary up to 6 months. Vasectomy is 7 days. Tubectomy is 14 days. Temporary disability, you will get the leave till recovery. Permanent, you will get the pension as per the guidelines, and the funeral benefits is going to be 15,000 rupees. Is that clear to everyone? Yes. Let's move to the next question. HIV positive mother who is taking a ART treatment delivers a healthy baby with a birth weight of 3 kg. Baby is normal. The ideal birth weight of a baby is 2.9 to 3 kg. Okay. Started ART treatment just 4 hours after the delivery. So mother is positive. Now she delivered a healthy baby. Birth weight is okay. she started a ART treatment just 4 hours after the delivery. What is the level of prevention here? What will be your answer, bacho? So there is a mother who is HIV positive. Followed by that, she delivered a baby, healthy baby, 3 kg. Now she started a prophylactic treatment in a baby. Now the risk factor is present, mother is positive, risk factor is there, but now they want to stop the disease to occur. When you have a risk factor present and you stop a disease to occur, that is a which level of prevention? Write down in the answers. That is a which level of prevention? It is a which level of prevention? HIV positive mother who is taking an ART treatment delivers a healthy baby with a birth weight of 3 kg. Started ART treatment just 4 hours after the delivery. What is the level of prevention? What is the level of prevention? What will be the level of prevention, bacho? Yes, the level of prevention is going to be the primary level of prevention. What is primordial? When you try to stop the risk factor to occur, that's going to be your primary level of prevention. When you have a risk factor present, you try to stop the disease to occur, that's going to be your primary level of prevention. Early diagnosis and treatment is going to be the secondary. Rehabilitation is going to be the tertiary. Now let's understand this level of prevention. Now let's understand the level of prevention. Now when we talk about this level of prevention, we have two phases. We have two phases. One is pre-pathogenic, before the disease. One is pre-pathogenic, other one is pathogenic. Other one is pathogenic phase. One is pre-pathogenic phase, another one is pathogenic phase. In pre-pathogenic phase, my dear students, we have a level of prevention. We have a primordial level of prevention, and we have a primary level of prevention. We have a primordial level of prevention and we have a primary level of prevention. In pathogenic phase, we have early secondary, and we have late tertiary. We have early secondary and we have late tertiary. Okay, now let's discuss what exactly is the primary level of prevention, what exactly is the primordial level of prevention, what exactly is the secondary level of prevention, and what exactly is the tertiary level of prevention. Chalo, level of prevention, first one, that is going to be your primordial level of prevention. So what is primordial level of prevention? When there is a prevention of occurrence of risk factor. Prevention of occurrence of a risk factor. Okay, now for example, if you change the water of the cooler every 15 days, every 10 days, there will be no mosquitoes. When there will be no mosquitoes, they will not enter to your room, they will not bite you, there will be no malaria. So the risk factor is what? Risk factor is the water of the cooler. And if you left it like that only, what will happen? Mosquitoes will come and gather to the dirty water. So in order to change the water of that cooler every 10 days, every week, what are you doing? You are trying to stop the risk factor to occur. What's the risk factor? Risk factor is the mosquitoes. When you are changing the water every 6 days, every 10 days, so mosquitoes are not coming. Such level of prevention, changing water of the cooler every 6 days, is going to be the primordial level of prevention. Is that clear to everyone? Yes, bilkul, Mir Mehran. Okay. Is that clear? Is that clear? Prevention of occurrence of risk factor is going to be the primordial level of prevention. And it is a which phase, bacho? It is a pre-pathogenic phase. It's a pre-pathogenic phase. Is that clear to everyone? Yes. Now next one is going to be the primary level of prevention. So what is primary level of prevention? That means there is a prevention of disease. There is a prevention of disease in presence of risk factor. In presence of a risk factor. For example, sir, what is the example of the primary level of prevention? Patient is having AIDS. patient is having AIDS. Now you know that AIDS patient is more prone to the opportunistic infections like pneumocystic jirovecii pneumonia. Now if I'm starting a clotrimazole in a patient prior to the what? Pneumonia, that is a which level of prevention? That is called as which level of prevention? That is called as primary level of prevention. That means risk factor is present, but you try to stop disease to occur. That is called as primary level of prevention. All the vaccines are which level of prevention? So they are going to be primary level of prevention. Okay, now my question to you guys is, a patient is coming to you with a painless hematuria. Okay, now you know painless hematuria is a diagnosis of what? Painless hematuria, usually bladder cancer. Okay, now patient has a painless hematuria, diagnosis of a bladder cancer, and you're using a BCG vaccine in a treatment. What is the level of prevention? BCG vaccine in case of a bladder cancer is a which level of prevention? Write down in the answers, comment section guys. Patient is having a bladder cancer. Now you are giving a BCG vaccine as a treatment. Now BCG vaccine for a bladder cancer is a which level of prevention? That is going to be the secondary level of prevention. Why? Because here BCG vaccine you are using as a treatment, and treatment, early diagnosis and treatment is a secondary level of prevention. But overall, all the vaccines are which level of prevention? All the vaccines are primary level of prevention. And what is the phase? That is going to be pre-pathogenic phase. It's going to be pre-pathogenic phase. Okay, next one is going to be secondary. Secondary level of prevention. What is the definition of a secondary level of prevention, guys? Early diagnosis and treatment. Now early diagnosis and treatment, my dear students, that is all the investigations. If you are going for the CBC, LFT, KFT, all these investigations come under which level of prevention? Early diagnosis. They come under the secondary level of prevention. That is early pathogenic. And then coming to the tertiary one, it's a management of complications and disability. Tertiary one is a management. It's the management of complications. And disability. And which phase? It's a late pathogenic. For example, clutches in the polio. Management of complications and disability. Okay, now let's discuss some examples. You answer me in the comment section, guys. Tell me, vaccines are which level of prevention? Yes, vaccines are primary level of prevention. Pap smear is a which level of prevention? Pap smear is a secondary level of prevention. Very good. Pap smear is a secondary level of prevention. Okay, mammography again is going to be secondary level of prevention. Okay, mammography is secondary level of prevention. Change of the water in cooler every week, that's going to be primordial. And use of mosquito nets again is going to be primary level of prevention. Is going to be primary level of prevention. Is that clear? Level of prevention is clear to everyone? Yes, all of you guys? Yes, let's move to the next question. If you want to check the incidence of deafness caused by the noise in office workers and factory workers after 1 year, which type of study you will be conducting? which type of study you will be conducting. Okay, so you want to check the incidence of a deafness by the noise in office. So currently it's 2024 December. Okay, currently it's a 2024 December, and now you want to check the incidence of a deafness after 1 year, 2025 December. So what will be the study conducted? What will be the study conducted? Write down in the comment section, guys. It will be very good. It is going to be a cohort study. It's going to be the cohort study. What is cohort study? It's a forward looking study, okay, which tells us from the cause to effect, which tells us about cause to effect or the risk factor to disease. What's the risk factor? So it's the noise. And what will be the disease? Deafness. Okay, what will be the disease? Deafness. So let's understand about the epidemiology first. What exactly is epidemiology? What are the studies in the epidemiology? And then based upon that, what are the numericals that they ask? So first of all, if we talk about the classification of an epidemiological studies, my dear student, we have observational, and we have experimental. We have observational and we have experimental. In observational, my dear students, we have two things. Number one is going to be descriptive hypothesis. First one is going to be descriptive hypothesis. What is descriptive hypothesis? There is a formation of hypothesis. Okay, you form a study, you form a hypothesis with the help of a time, place, person. So you form the hypothesis, descriptive hypothesis, formation with time, place, person. And then there is an analytical hypothesis. That is, you test these hypotheses, and testing is done with the help of these studies. What are these studies? So they are cohort study, they are case control study, we have cross-sectional study, and the next one we have ecological study. Okay, so first you form the hypothesis with the help of a time, place and person. Then you test these hypotheses with the help of a studies. We have cohort study, we have case control, we have cross-sectional, and we have ecological. And then there is a hypothesis confirmation. There is a hypothesis confirmation with randomized controlled trial. We have a clinical trial, we have a field trial, and community trial. Okay, now let's discuss about the first one, cohort study. For example, how do you form the hypothesis? For example, time. Some disease are formed, some disease are seen in, conditions are seen in a particular period of time or a particular place. For example, Africa, Burkitt's lymphoma; China, nasopharyngeal carcinoma; Bihar, West Bengal, you have leishmaniasis, Kala Azar; South states, you have HIV and all. Then the persons, breast cancer is more into the females, lung cancer is more seen in males. Okay, so you form the hypothesis with the time, place and person. Then you test these hypotheses with the help of studies. Now what is study? First, cohort study. It's also called as prospective study. It's called as prospective study. That is a forward looking study. It is a forward looking study. Okay, it is also called as cause to effect study or risk factor to disease study or the risk factor to disease study. Okay, what is a cohort study? So it's a prospective study or the forward looking study, or the cause to effect study, that is a risk factor to disease study. What are the classical examples? So the examples are, for example, smoking to lung cancer, or alcohol to liver cancer. So patient is smoking, 2024 he started smoking. Now after 10 years I will check whether he will develop the lung cancer or not. What are the outcomes? So this study that I will do, how much time it will take, what is the risk? This is called as we study cohort study, in which we are going in the forward direction study. Now this study, that is from the risk factor to disease. Now for example, you are starting a study in the 2024 and you will check for next 7 years, next 8 years. That means it is a time consuming study. It is a time consuming study, number one. Number second thing, in cohort study, my dear student, you need a continuous follow-up of a patient. Yes, so that follow-up is needed. Okay, and then one more thing, it is an expensive study as well as compared to the case control, because you need to do investigations going on in order to check the progression of the disease. Okay, so that is time consuming and follow up is needed. Now the results are calculated by the strength of association and is given by, we calculate the results by relative risk, attributable risk and popular attributable risk. So relative risk, attributable risk, popular attributable risk and the incidence, they are checked in which type of study, bacho? They are checked in cohort study. Sir, what exactly is relative risk? I'll be showing you one question on the relative risk, how to calculate, so then it will be clear. Is that clear? Cohort study, sir, it's a forward looking study. Number one thing, it's a cause to effect study, that is a risk factor to disease study. The examples like smoking to the lung cancer, and the strength of association is given by relative risk, attributable risk and popular attributable risk. Now we have a mixed study design in which we have a cohort plus case control. Now what exactly is case control? It's an opposite of a cohort. If cohort is a forward looking study, this is a backward looking study. If it's a risk factor to disease, that's a disease to risk factor. It's cause to effect, that is a effect to cause. If it's prospective, that is retrospective. For example, a patient is coming to you with a diagnosis of a lung cancer. What is the first thing you will ask? History of smoking. Patient is coming to you with the liver cancer. What is the first thing you will ask? You directly go to the risk factor. Okay, you will ask about the alcohol history. Is that clear? So that is going to be a case control study. Now case control study, that is a very fast study. Why? Because risk factor is there, you already have a data, disease is present. Okay, follow up is needed? No, that is a fast study. I will also discuss in after few questions, I will also discuss the question on a case control study so that you have an idea. Okay, case control is also for the rare diseases. Yes, it's for the rare diseases. Chalo. Now the mixed study designs, we have case control plus cohort. For example, what is retrospective cohort study? First of all, the direction is forward, but we go back in time 10 to 20 years, and from the hospital records or data, we found out exposed, non-exposed people or data. We check in current time that how many of those exposed have developed the disease. So if disease direction is forward and then you go backward, simple words, this is going to be your retrospective cohort. Okay, forward and then backward, it's going to be your retrospective cohort. Sir, what is mixed cohort? Mixed cohort is forward, then backward, then you are going again forward. This is going to be your mixed cohort studies, that is retrospective cohort plus prospective cohort. If we do another study for 10 to 20 years in forward direction after the retrospective cohort study, that is going to be your mixed cohort study. Did you understand, guys? The first direction is forward and then you go back in time. This is a mixed study design called as retrospective cohort study. Then the mixed cohort study is retrospective, you're going forward then backward, then again prospective cohort, you do again the study for next 10 to 20 years in the forward direction. That's going to be your mixed cohort study. That's going to be your mixed cohort study. Is that clear? Cohort, mixed cohort and retrospective cohort is clear to everyone? Yes, they will simply ask the question. You have to see whether the study is cohort study, whether the study is case control, whether it's a cross-sectional or whether it's an ecological study. So this is a forward direction, this is a backward direction, and this is at time, at given point. This is at given point. Is that okay? Now solve the question, guys. A study was conducted to assess the association between the smoking and the lung cancer. The following data was collected. Okay, smokers, lung cancer present are 60 people. Okay, then lung cancer absent are 40 people. The total are 100. Non-smokers present are 20, absent 80, total are 100. What is the relative risk of developing lung cancer among smokers compared to non-smokers? So let's solve the question relative risk. So how do you calculate the relative risk? You already know incidence in exposed okay, upon incidence in non-exposed. Incidence in exposed upon incidence in non-exposed. Incidence in exposed they are smokers है ना, and non-exposed में non-smokers. चलो, now let's calculate the incidence in exposed. Incidence in exposed, चलो 100 people, so that is going to be, write it down, that's going to be lung cancer among the smokers, that's going to be 60 plus total of 100, that's going to be 0.6. that is incidence in exposed. Incidence in non-exposed, that is 20 by 100, that is 20 upon 100, that is 0.2. so 0.6 upon 0.2, what will be your answer bacho? That is 3.0. What is the answer guys? 3.0. That means smokers are 3 times more likely to develop the lung cancer compared to the non-smokers. What will be the answer for this? 3.0. Did you understand guys? So incidence in exposed 60, 100, 60 by 100, that's going to 0.6, and then 20 by 100, that's going to 0.2, that's 3 is the answer. That means smokers are 3 times more likely to develop the lung cancer compared to the non-smokers. Is that clear? Relative risk, you understood how to calculate the relative risk? Incidence in exposed upon incidence in non-exposed. Incidence in exposed, that is smokers present having a lung cancer, 60 out of 100 people. Non-smokers, so 20 people out of 100 people. Incidence in exposed is going to be 0.6. Incidence in non-exposed is going to be 0.2. Divide kar lo, normal thing, that's going to be 3.0. That means smokers have 3 times more chances to develop the lung cancer compared to the non-smokers. That is going to be relative risk. And relative risk is calculated in which study? Relative risk is calculated in which study? That's going to be your cohort study. That's going to be the cohort study. Is that clear? Is that clear to everyone? Same simple relative risk they ask from the numericals. Last exam they also asked the same questions, different data. All you have to do is incidence in exposed upon incidence in non-exposed. That is your answer. Chalo. A woman in the age group, yes, a woman in the age group of 25 to 45, 10th pass, married or divorced, belongs to the same village community with a well communication skills. She is selected by the village personnel. She is eligible to work as a trained eye, an Anganwadi worker, an accredited social health activist, or an auxiliary midwife. Your answer is going to be ASHA, that is accredited social health activist. So what is the criteria for ASHA? It's already given in the question, my dear students. 25 to 45, she should be 10th pass, married or divorced. She should be a resident of a same village with a good communication skills. Same village personnel with a good, she should be a resident of a same village with a good communication skills. Age 25 to 45, 10th pass. Your answer is going to be ASHA. Now let's discuss about the grassroots level workers, the village level workers. Okay, so what are the village workers? We have ASHA, accredited social health activist. We have AWW, Anganwadi worker. We have TBA, that's a traditional birth attendant. We have VHG, that's a village health guide. Okay, one question was asked, out of which of the following is not a village worker? Out of which of the following is not a village worker? FMGE PYQ was asked. Your answer is going to be, कौन सा नहीं होता है? Auxiliary nurse midwife. ANM is not a village worker. याद रखना, ठीक है? Just remember that. Now let's discuss about these village workers, population, education, the training duration, and they are trained by who. Okay, now the location, if I talk about, it is at the level of village, you already know. Okay, traditional birth, the population is 1 per 1 village. The population is 1 per 1 village. Education is not required. Education is not required. Training duration for 30 days. and she's trained by multi-purpose worker female and medical officer. Multi-worker female and medical officer. If I talk about the next one, that is going to be your village health guide. She's at the level of village. Okay, 1 per 1000 population. The education should be 6 pass. Okay, the training duration is around 200 hours or 3 months. She is trained by medical officer. She is trained by medical officer. Now the important one, that is accredited social health activist, ASHA. She is at the level of village. Okay, it's 2 per 1000. Okay, before it was 1 per 1000, now it's 2 per 1000. The education minimum was before 8th pass, now it's 10th pass. Okay, the training of 23 days for the ASHA, and she's trained by Anganwadi worker, multi-purpose worker female and a medical officer. Then Anganwadi worker, it is seen in the ICDS center. Okay, second, the population in plains is 1 per 400 to 800 in plains and 1 per 300 to 800 in hills. Followed by that, the education for this is 12th pass. The education required is around 12th pass. The training duration is 4 months, and she is trained by community development project officer. She is trained by community development project officer. So this is all about a grassroots level workers that works at the village level. Okay, now main things, what about the functions of ASHA? Write down in the comment section. Functions of ASHA. What are the functions of ASHA? Number first thing is she is a part of a yojana, a part of a JSY, Janani Suraksha Yojana. She's a part of a JSY. Number second is she is doing home delivery of contraceptions. Home delivery of contraception. Okay. Number third is give the treatment for the minor ailments. She gives the treatment for minor ailments. And 4 is active disease surveillance. Active disease surveillance for like leishmaniasis, tuberculosis and filariasis. So this is all about functions of ASHA. She is a part of a JSY, Janani Suraksha Yojana. She does the home delivery of the contraception. She gives the treatment for the minor ailments and active disease surveillance. So they have 3 types of surveillances. Remember that we have 3 types of surveillance. We have active surveillance. We have pregnancy tracking as well. We have active surveillance. We have passive surveillance, and we have sentinel surveillance. So what is active surveillance? Active surveillance means when a health worker is going to home and check for the disease. Okay, what is passive surveillance? When a patient is coming to the hospital and takes the treatment, for example, non-communicable diseases. Okay, and what is sentinel surveillance? That is particularly used for the sexually transmitted diseases like AIDS. Is that clear? So active surveillance, passive surveillance and sentinel surveillance. Active, health worker is going; passive, disease person is coming to the hospital; and sentinel, exclusively for the sexually transmitted diseases. So here a woman is there, age group of 25 to 45, 10th pass, resident of a same village with a good communication skills. She is allowed to work as ASHA. So remember the full form as well. Sometimes in options they will not give a ASHA only, they will write accredited social health activist. Is that clear to everyone? Is that clear to everyone? Yes, write down in the comment section. Write down in the comment section. All clear? So we can go ahead. Chalo. Next one. A blood pressure of 3 different groups A, B and C was measured and the mean blood pressure calculated out of it. The 3 means are different. The most appropriate test to determine the significance of difference between mean is. So it is about a test of significance. Now tell me the answer, guys. Before going to the answer, let's discuss about the test of significance. So whenever we are talking about the test of significance, my dear students, we have parametric and non-parametric tests. So we have, first of all, before going to that, we have to check what type of data we have given. Okay, so we have 2 types of data. One is going to be quantitative data, another one is going to be a qualitative data. What is quantitative data? The data that can be measured. What is quantitative data? The data that can be measured. What is qualitative data? That can not be measured. For example, in quantitative data, blood pressure, can you measure that? Yes sir, we can measure the blood pressure. For example, anemia, can you measure that? No, you can just know the anemia, the type of the anemia. Okay, can we measure the anemia? No. So let's discuss about the first parametric test. What is the first one, guys? Parametric test. So we have a parametric test and they are used for which type of data? They are used for quantitative data. Understand very well, guys. It's a very important question that they ask. What is quantitative data? In which a measurement is possible. What is quantitative data? In which the measurement is possible. And in this type of tests, that are the parametric tests, we are usually calculating mean and standard deviation. So mean and standard deviation in a question will be given as a hint. You will know that what we have to follow is a parametric test. Now the parametric test we have, number 1, we have student t-test. Okay, in student t-test, my dear students, we have paired student, and we have unpaired student. Now what is paired student t-test? Understand the thing. For example, you have a 10 people out there. Okay, you have 10 people out there having a cholesterol. Can we measure the cholesterol levels? Yes sir, we can measure. Now patient is coming to you having a cholesterol levels of more than 250. Now what is the drug you will give? You will start the hypolipidemics, statins. Okay, so there is a one group of people having a hypercholesterolemia, having a high cholesterol levels. So I am starting a drug atorvastatin in these 10 people. In this one group of 10 people, I am starting the drug on the 1st of December. Okay, and the drug is atorvastatin. After 1 month, I am checking the again cholesterol levels of the same group. So before the intervention and after the intervention, I have a same group. Are you understanding my point? I am saying that I have one group, the patient, 10 people in the group are having a high cholesterol levels, 250. Now I am starting a hypolipidemic in these 10 people. Now before and after, I'm comparing the same group. After 1 month, I'm again checking the cholesterol levels in a same 10 people. And when you are doing the test in a one group before the intervention and after the intervention, the test you are doing is called as paired student test. And before the intervention and after the intervention is a one group, that is a paired student test. Now we have two groups, both of them have cholesterol levels high. One group you are telling change the lifestyle, another group you are saying that go for the hypolipidemics. After 1 month you are comparing these two groups, the cholesterol levels, the quantitative data, you are comparing between the two groups. That time the test used is unpaired student test. Unpaired student test. And for the quantitative data, the data that you can measure, if you have more than two groups, if you have more than two groups, the test is called as ANOVA test. The test is called as ANOVA test. Is that clear to everyone? Is that clear to everyone? I'm saying that first of all, check the type of the data. You have a data given, whether it is a quantitative data or a qualitative data. If the data is given that the measurement is possible, you are going with which test? You are going with a parametric test. What are the parametric tests? We have a student T test, either paired or unpaired, or we have an ANOVA test. If one group, you mark paired test. If two group, you mark unpaired. If three group, you mark ANOVA test. Is that clear to everyone? Is that clear to everyone? Number first step should be, you need to check what type of data it is, whether it is a qualitative data or a quantitative data. Let's go to the question and understand. See, the blood pressure. Can you measure the blood pressure? Yes or no? Write down in the comment section. Can we measure the blood pressure? Yes sir, we can measure the blood pressure. That means the blood pressure checking is a which type of data? Blood pressure is a which type of data? It's a quantitative data. Okay, now it's a quantitative data. Now it's a quantitative data, measurement is possible. Now what are the parametric tests? Either we have to use unpaired, either paired, or either ANOVA test. If one group I'm going with paired. If two group I'm going with unpaired. If three group I'm going with ANOVA test. So blood pressure of three different groups A, B and C was measured and mean B blood pressure calculated out of it. I told you mean and two groups. So mean blood pressure was calculated out of it. The three means are different. The most appropriate test. What is the test of significance that you will use between their mean is? What will be the answer, bacho? What will be the answer? Now when you have a quantitative data with the three groups, more than two groups, your answer is going to be blood pressure A, B, C, mean, test of significance. What will be your answer? Yes, the answer is going to be very good, ANOVA test. Sir, blood pressure is a quantitative data. So three groups are there. Mean has been calculated. I am going with the ANOVA test. I'm going with the ANOVA test. I'm going with the ANOVA test. Okay. Okay. No problem. Answer me this one. I will get to know whether you know this or not. A cardiologist wants to study the effect of an atorvastatin drug. He notes down the initial cholesterol levels of 50 patients and then administer the drug on them. After a month, he measures the cholesterol level again. Which of the following is the most appropriate to test the statistical significance of the change in the cholesterol levels? What will be your answer for this question? Now check how many groups are there. Okay, are they before the intervention and after the intervention is the same group or different group? What will be the test you will do? Let me know. What will be the test you are going to do? What is the test you will do in this condition? Write down in the comment section, guys. All of you. Yes, very good. The answer is going to be paired t-test. The answer is going to be paired t-test. Very good. The answer is going to be paired t-test. Now, is this easy one? Yes. Now, can you solve the questions based upon such topic? Because this is an important topic. They usually ask the questions from this topic. Okay. Chalo. Now, non-parametric test. Just one group is paired, two group is unpaired, and more than two groups is ANOVA. Okay. Now next one, non-parametric test. In non-parametric test, the type of the data we have is a qualitative data. The type of a data we have is a qualitative data in which the measurement is not possible, okay. And usually the question will mention to calculate percentage or proportion. Question में mention होगा क्या, percentage or proportion. Now whenever a mean is mentioned, standard deviation is mentioned, you go with the parametric test. You have an idea, you have to mark what parametric test. And whenever a standard percentage or the proportion is mentioned, you have an idea that you have to go with the non-parametric test. In non-parametric test, my dear student, we have a sign test for one paired group. If one paired group, you go with the sign test, okay. And the second one, we have a chi-square test, 2 or more than 2 groups. CHI, chi-square test, okay, either 2 unpaired or more than 2 groups. The test is going to be chi-square test. The test is going to be chi-square test. So answer me this question now. The test of significance done for 2 or more proportions. The test of significance done for 2 or more proportions. What will be your answer for this one? Yes, the test of significance done for 2 or more proportions. Your answer is going to be? Your answer is going to be? Yes, C. That is a chi-square test. What is your answer, bacho? Chi-square test. Because for one paired group in the non-parametric test, the answer is going to be sign test. If more than 2 or 2, the answer is going to be chi-square. Okay. Chalo. Is that clear? Is that clear? Test of significance is clear to everyone? Yes? Test of significance is clear to everyone? Chalo. Next question. A case control study is a type of observational study in which sorry. A case control study is a type of an observational study in which two existing groups differing in the outcome are identified and compared on the basis of some supposed causal attribute. All of the following are the advantages of the case control except. We can easily answer this question. We have just discussed all of the following are the advantages of the case control except. All of the following are the advantages of the case control except. Your answer is going to be yes. Very easy. Relative risk can be calculated. No sir, the relative risk can be calculated in which type of study? So that can be cohort study. That is cohort study. How to calculate incidence in exposed by incidence in non exposed. Okay. Case control. Odds ratio is calculated there. Nature with medicos. C. No, C is odds ratio. Odds ratio is calculated in case control. Okay. Relative risk is not calculated over there. Okay, it's a cost effective. Yes, case control is cheaper than the cohort because cohort needs a continuous follow-up, continuous investigation, so it needs more time and more money. But compared to the cohort, it's inexpensive and cost effective. Odds ratio can be calculated, yes, and useful in rare disease. Yes, B is seen in cohort study. Very good. Now, case control study, it is also called as backward study. It is also called as backward study. It is study is from the disease to risk factor. So it's also called as retrospective study. It's also called as retrospective study or effect to cause study or the outcome to exposure study or the effect to cause study or the outcome to exposure study. For example, what is a classical example? Number of lung cancer patients had exposure to smoking in the past. So Lung cancer is a disease, and exposure to the past is a risk factor. Exposure to the smoking is a risk factor. So disease to risk factor is a case control study. It's a very fast study. There is no follow-up because there are no NIV cases. It is also called as Triage study. It's also called as Triage study, and the strength of association is given by odds ratio, which is also called as cross product ratio, which is also called as cross product ratio. So simple question was asked, cross product ratio is calculated in which type of study? That is going to be your case control study. That's going to be your case control study. Okay, now next question. In a train accident, there were 74 dead, 4 were severely injured, 5 moderately injured, and 22 mildly injured. The color coding in the triage from highest to lowest category is, what will be your answer? From highest to lowest category is, that's going to be answered D, the red, yellow, green and black. That's going to be red, yellow, green and black. Okay, now let's understand what exactly is the triage. Very good. The triage is the segregation of a patient based on the chances of survival with best possible treatment available, not on the basis of severity of illness. So we have 4 groups. How many groups we have? We have 4 groups. We have red, given the highest priority. We have red given highest priority, or those who need an immediate resuscitation, or those who need an immediate resuscitation. Okay, life-saving surgery or resuscitation in 0 to 6 hours. In 0 to 6 hours. Then we have a yellow, surgery or resuscitation needed around 6 to 24 hours. 6 to 24 hours, and they are given a medium priority. उनको क्या मिलती है? Medium priority. Then we have a green color, given low priority. Given low priority, they are the ambulatory patients with the minor injuries. Then we have a black, or almost dead or moribund patients about to die. They are about to die patient. We have a black, given a least priority. Given least priority. So what is the order? So order is red, yellow, green, black. Remember the order. Red given a highest priority, yellow given a medium priority, green low priority, and black a least priority, and the black with the least priority. Is that clear to everyone? Is that clear to everyone? Yes? All of you in the comment section? That was about the triage. That was about the triage. We still have more 30 slides around. Chalo. Okay. Chalo. Is that clear to everyone? Yes? Anyone, any doubt so far? Because we have a quick recap of what exactly we have studied today. Okay, let's have a quick recap of all the topics and chapters what we have studied today, and we'll see for the PSM part 3. If everything goes well, we will do PSM part 3. If not, then let's see. Okay, so let's have a quick recap of what exactly we studied. That is more important. You might be tired as well, but chalo. Revision is more important rather than going for the next thing. Let's have a quick fast revision whatever we studied. We started first from the Anemia Mukt Bharat. I told you this is a scheme launched by the government in order to decrease the prevalence of anemia 3% every year. Okay, there is a strategy, 6 strategy, 6 beneficiaries. What are the 6 beneficiaries? 1 2 3 4 5 6 beneficiaries, 6 institutional mechanisms and 6 interventions. Is that clear? After that, I mentioned that as per the Anemia Mukt Bharat, the pregnancy and lactation, you will remember importantly, there is 60 mg of iron and 500 mg of folic acid, 500 micrograms of folic acid given. Is that clear? Daily. Okay, apart from that, 400 micrograms of folic acid daily as per the normal, and if patient is having a history of a neural tube defect, then you have to go for the 4000 micrograms. Is that clear? But as per Anemia Mukt Bharat, normally में कितना देना है? 500. Is that clear? Iron 100 mg, and if patient is having a mild to moderate anemia, you give 200. After that, antenatal visits are 13 to 14, 12 to 14 visits. Minimum as per India is 4, as per WHO is 8. Infant parasite rate, active disease transmission by API. Best indicator of the recent malaria transmission is infant parasite rate. Annual blood examination rate, ABR, is a best indicator for the operational efficiency of the worker. Followed by that, how do you diagnose the malaria, my dear students? So we go for the peripheral blood smear, 2 smears, thin and thick. Thin is telling me about the species and thick is telling me about the conformation. And also we are going for the rapid diagnostic kit using antigen detected by the protein, histidine rich protein. After that, the treatment in northeastern state is going to be artemether, lumefantrine and primaquine, and in other states is going to be artesunate, sulfadoxine and primaquine. Side effect of chloroquine is bullseye and QT prolongation. If it's Plasmodium vivax, the drug of choice is going to be chloroquine. Malaria with the pregnancy, chloroquine is going to be drug of choice for all trimesters if it's Plasmodium vivax. If it's falciparum, first trimester is quinine, second based upon northeastern ACT-L and other is ACT-SP. Prophylaxis, you are going 2 weeks before and 4 weeks post return, doxycycline, mefloquine and etovoquone. Okay, then the demographic transition model, you have to remember the sequence. You have high stationary, early expanding, late expanding, low stationary and then declining. Followed by that, we have phases of demographic cycle. India is in the late expansion stage. If the interval between the marriage and the first child, that is going to be formation. Entry of organisms with the maximum infectivity is a generation time. Interval between the primary and secondary is a serial one. Entry of organisms to the detectable antibody present is going to be window period. Window period. Entry of infection to the symptom of the disease is going to be incubation period. If the separation of a suspected or the healthy person till the incubation period, that's going to be quarantine. And separation of a diseased person till the period of communicability, that's going to be isolation. All of the following are the primary features except the night blindness, that is a secondary feature. Followed by that, remember, all these features are reversible except the keratomalacia. It will cause an absolute blindness. Is that clear? Then first sign is going to be conjunctival xerosis. First symptom is going to be night blindness. Total 9 doses are given, 70 lakh international units. Less than 6 months is 50,000. 6 to 12 is 1 lakh international unit. More than 1 year is 2 lakh international. If the weight of the baby is less than 8 kg, you are going with the 1 lakh international units. This spot is called as Bitot spot, most common clinical symptom. Then thiamine will cause beriberi, Wernicke's and Korsakoff's. Remember Goa and confabulation and retrograde amnesia. Remember for the riboflavin A, riboflavinosis, niacin में 6Ds, pantothenic burning feet syndrome, B6 peripheral neuropathy, biotin is alopecia, B9 neural tube defect and megaloblastic anemia, B12 with subacute degeneration of myelin. Remember MMA levels and homocysteine levels both elevated is a diagnosis of a B12. One normal, MMA normal and homocysteine elevated is a folate deficiency. Scurvy with vitamin C. Osteomalacia, osteoporosis, rickets is going to be vitamin D deficiency. Tocopherol is an antioxidant causing hemolytic disease of newborn, along with that ophthalmoplegia. Vitamin K is a hemorrhagic disease of newborn. We have K1, K2 and K3, fat soluble and the water soluble. Selenium will cause cardiomyopathy, Cation disease. Zinc will cause acrodermatitis enteropathica. Remember 1 to 5 lesions is called as possibacillary leprosy. More than 5 is going to be multibacillary. 3 drugs, clofazimine, dapsone and rifampicin. Most potent is going to be rifampicin. Most old is going to be dapsone. If a resistance to rifampicin, the drugs used are clarithromycin and minocycline. Then we discuss about the duration of the treatment. 6 months in a possibacillary, 12 months in the multibacillary. Remember, type 1 lepra reaction is going to be type 4 hypersensitivity reaction. Type 2 lepra reaction is going to be type 3 hypersensitivity reaction. Most common nerve involved is going to be ulnar nerve. Most common cranial nerve involved is going to be facial nerve. Nerve kit update is brown for the anorectal discharge, having doxycycline and cefixime as a drug. Cefixime 800 mg is start with you, followed by 2 tablets every day for the 1 week for a doxycycline. This is a program for the National Leprosy Elimination Program. This is going to be your SAPNA for leprosy elimination, and this is the National Tuberculosis Elimination Program for TB. By 2025 they say will eliminate, but as per the SGD it's 2025. 30. Remember the BPAL M regime, where M stands for the moxifloxacin, and incentives update is 1000. Remember, if there is a correct order of sequence, that's going to be symposium. If there is no correct order of speech, that's going to be panel discussion. Seeing is believing, learning by doing is the active principle for the demonstration. Example, ORS. To break the bad news, you go with the spikes technique. Decrease weight for age is underweight, acute plus chronic undernutrition. Low weight for height, acute malnutrition wasting. Low height for age is chronic malnutrition. Remember Kwashiorkor and marasmus, hepatomegaly, splenomegaly, flag sign, protruded abdomen. Deficiency of protein is Kwashiorkor. Protein and calorie, prominent ribs, low fat, no fatty liver, voracious feeder, muscle wasting is going to be your marasmus. Remember, pre-exposure prophylaxis is 0, 7, 21 or 28. Post vaccinated is 0, 3, not vaccinated 0, 3, 7, 14, 28 as per SN regime. As per Thai updated Red Cross regime, 0, 3, 7 and 28. Opportunistic infection 500 to 200 is tuberculosis, candidiasis and Kaposi. Less than 200 is PJP, pneumocystic jirovecine pneumonia and cryptococcal meningitis. 100 to 50 is toxoplasmosis. Less than 50 is going to be CMV retinitis. PSA by appearance and cotton wool spot are the classical finding of the CMV retinitis with a drug of choice of jancyclovir. Multiple eccentric dots with the clinical features of seizure along with the hydrocephalus, chorioretinitis and intracranial calcification is the diagnosis of a toxoplasmosis. Pyrimethamine, sulfazidine and leucovorin is going to be the treatment of toxoplasmosis, and in pregnancy the treatment is going to be spiramycin. This is a Kaposi sarcoma malignancy associated with an HIV, HHV8. Treatment is going to be surgery and chemotherapy. Remember, as per the ASI Act, sickness benefit is 90 days, extended is 2 years, maternity is 6 months. Remember the salary as per the given condition. If you try to stop the risk factor to occur, it's going to be primordial. Risk factor is present, you try to stop the disease is primary. Early diagnosis and treatment is going to be the secondary. Managing the complication and disability is going to be the tertiary level of prevention. Cohort study is a forward-looking study. You check the relative risk, you check the incidence, attributable risk and popular attributable risk. It's a time-consuming and expensive study because it needs more follow-up investigations. Followed by that, if you're going into the forward direction and then backward, it's going to be retrospective. If you're going into forward then backward, then forward is going to be the mixed direction. How to calculate the relative risk? That is going to be incidence in exposed upon incidence in non-exposed. ASHA functions. She's a part of a Janani Suraksha Yojana, home delivery of contraception. She gives a treatment for the minor ailments and goes for the active disease, surveillance for leishmaniasis, tuberculosis and filariasis. Then we have a village workers, ASHA, Anganwadi worker, traditional birth attendant and the village health guide. Which of the following is not, if they ask? Auxiliary nurse, midwife. ASHA 2 per 1000, 10th pass, 23 days training is there. Then the tests of significance, we have a parametric test and non-parametric test. Parametric, we have a quantitative data in which the measurement is possible. They will be mentioning to check the standard deviation and the mean. For paired student t-test is a 1 group, unpaired is going to be 2 group, and more than 2 groups you are going with the ANOVA test. And non-parametric may sign test, 1 pair group, chi-square is more than 2 or 2. Then the examples, then we discuss about a case control, the backward study in which the cross product ratio or the odds ratio is calculated. Followed by that, we discuss about the triage. What is the sequence? Red, yellow, green and black. Highest priority to be given to red and the least given to the black. Is that clear? So that was all about the PSM part 3. Anyone, any doubts? Everything is clear? Everything is clear, guys? Yes? Now you can watch it on the 2x speed again because I've included all the important topics, all the high stuff. Okay, you can go through part 1 as well. And if you have any doubts, you can ping me on the Telegram. Your text should be only study related. Okay, you're more welcome. And keep studying, keep revising. OB-GYN, maybe. OB-GYN, yes, I will take OB-GYN as well. Part 3. 2 parts are already done, but the part 3 mostly gynecology, ectopic pregnancy and abortion I'll be taking on the 11th. Hopefully, OB-GYN will be taking on the 11th. Is that clear to everyone? Any more doubts? All good. I hope session was interactive enough. All the students who keep texting and answering, thank you for your interaction. So keep studying. All the best. OB-GYN, I'm saying OB-GYN I will take after 2-3 days, okay? Then followed by that we will go with the pathology, and followed by that we go with the pediatrics. Okay, so you can watch out these videos, all the important videos by the faculties. Watch them, they are crisp and concise. Okay, don't forget your primary notes. At a 2x speed you can at least revise these all the things. Thank you everyone. Okay, so with this I'll take a leave. Part 3, PSM part 3, yes, I'm not sure, but yes, I will try to deliver. I'll make a time, I'll find the gap in between, I'll deliver the part 3, because if we still go with the part 3 it will be a long 4-hour session, and most of you are tired. So let's end it here only. So keep studying guys, keep solving questions, give GTs, analyze your GTs, okay, and don't compare your preparation or don't compare your knowledge with anyone. You run your own race. Okay, it's a screening exam, you just need 150. No matter if you're good at OB-GYN, someone can be good at PSM, someone can be good at pharmacology. You cannot be good at all 19 subjects, okay? But yes, try to be smart, okay? Go through, recall sessions of FMG and NEET PG questions. Same topics will be there, okay? Questions will not be repeated, but the topics will be the same, okay? Chalo, so for this I must leave. Take care, keep